Good afternoon. This meeting will now come to order. Please note that this meeting is being recorded. So good afternoon. My name is Elizabeth Landsberg, and I am the director of HCI, the Department of Healthcare Access and Information. And I am truly thrilled to welcome you to the first meeting of California's Healthcare Affordability Board. We are here to work together to move California's healthcare system to a lower cost, higher value system. This will take all of us working together, and I think we can make a real difference for Californians. So I want to start with some thanks. Some folks are here in the room who helped make this day happen many years ago, and others are online. And I want to appreciate those who sat in rooms together before the pandemic. You were an unlikely group of folks who came together: consumer groups, labor, provider groups, health plans, and payers who knew that something had to be done about the unaffordable, continuing increasing healthcare costs. And you came together and the Office of Healthcare Affordability was born. So this is both a culmination of a lot of work and very much a beginning as well. So thank you to all of you for your vision. I want to thank Dr. Ghaly. When he hired me to be OSHPD's director, it was in part to get OCA over the finish line, and very much appreciate Secretary Ghaly's vision and leadership, as well as the commitment and support of the governor. I also want to recognize Dr. Wood for being OCA's legislative champion, working with us with many stakeholders over a long time to get to this moment, and also appreciate very much Dr. Pan when he was in the Senate for having a big impact on this language. Last and very much not least, I want to thank my incredible team at HCI who thought through every single detail to make today happen. In a moment, I'm going to ask members of the board to introduce themselves and to talk about why this is important to them and why they sought to be on the board. And so I just wanted to start by doing the same myself. 23 years ago, when I started in healthcare advocacy at Legal Aid of Northern California, 22% of Californians were not covered, and there was nowhere for us to send them. California has done a remarkable job in expanding coverage. We implemented the Affordable Care Act in spades. We expanded Medicaid, and in fact, did Medi-Cal for All is about to become a reality. So California has succeeded in getting people coverage, and yet cost is still a major barrier to access for consumers. So absolutely, the next critical frontier in healthcare access is affordability, and it's a great honor to be part of this work. I'm glad I started my career in healthcare working directly with consumers. And I remember folks, as you do, I remember talking to people who couldn't get the care that they needed for themselves or for their children because of the cost. I remember people who delayed getting diagnostic care and developed conditions that could have been treated had they gotten that diagnostic care. People who went to the emergency room and were saddled with very high healthcare bills, and people who didn't go to the emergency room because they were worried about the cost and worried about being saddled with that care. And so they are all with me today as we start this work. But we know that not all healthcare consumers are not a monolith. Black and Latinx healthcare consumers, health consumers who don't speak English well, those with disabilities, low-income consumers have more barriers. Cost is a bigger barrier for them, and they have greater difficulties accessing the care that they need. So our quality and equity measures are so important as part of this language, the work that we're going to do to set benchmarks for primary care and behavioral health to drive to a high value system. So I hope that we center healthcare consumers and also remember that they are not a monolith. With that, looking forward to start this work with each of you to help Californians have healthier, better lives, which is what this is all about. In terms of the agenda, on the next slide, we have our agenda. We will have board member introductions, followed by an orientation to the Office of Healthcare Affordability, its statute and board roles. Next will be an overview of the Bagley-Keene Open Meeting Act, the election of a chair, and a discussion of spending targets. We will take public comment at items 2 after the board orientation, item 3, which is election of the board, and item 6, and at the end also have time for general public comment. With that, I'm very excited to swear in the members of the board, which is a fun thing that we get to do. So I will conduct the swearing in with a different piece of paper. All right. So we'll do this all together, please. I, and your
Sandra
name,
Hernandez. Sandra
do
Hernandez.
solemnly swear or affirm
Do
that I will
solemnly swear or affirm.
And we are pleased to be joined by board member Dr. Sandra Hernandez, is in Los Angeles. Thank you, Sandra, for reading along. That I will support and defend
I will support
the
and defend
Constitution of the United States and the Constitution of the State of California
the Constitution of the United States and the Constitution of the State of California
against all enemies, foreign and domestic.
against all enemies, foreign and domestic.
That I will bear true faith and allegiance
That I will bear true faith and allegiance
to the Constitution of the United States and the Constitution of the State of California.
to the Constitution of the United States and the Constitution of the State of California.
That I take this obligation freely
That I take this obligation freely
without any mental reservation or purpose of evasion.
without any mental reservation or purpose of evasion.
And that I will well and faithfully discharge
And that I will well and faithfully discharge
the duties upon which I am about to enter.
the duties upon which I'm about to enter.
With the swearing in completed, we have officially established a quorum, and it's wonderful to have all 8 members, 7 here in person. And thank you, Dr. Hernandez, for joining us online. So the board has a vital mission for Californians, and it's important for the public to know who you are and again, why you stepped forward to do this work. So I will ask each board member to share why this work is important to you, and I'll ask you to try to keep it to 2 minutes if you can. And with that, I'm happy to start with Secretary Galley. And you do need to push the mic button to get it.
Got it.
Thank you.
Okay. Thank you, Director Landsberg. Elizabeth, thank you so much for opening up this meeting. And as I often have a chance to say, I get to stand on the shoulders of lots of folks who worked for years and decades, literally, to get to these moments that I have the privilege to be a part of. And I think this is similar to many of those we talked about, Health for All, and the expansion, so many things that Covered California has been able to do because of the fearless leadership of Californians who served in the legislature, who led departments before, who have been on the front lines with people across California asking what matters and how do we lift that up in Sacramento and across the state. And this is really no different in so many ways. I had the privilege of leading the Healthy California for All Commission with some of you, many of you participating. And I think it was just a really important discussion about what matters in the health system, and affordability is such a key piece of that. I have the privilege of thinking about how to connect the dots, whether it's at DMHC or DHCS or HCI or even social services. How do we think about issues of affordability in the context of what matters in Californians' lives? And this concept that it's not a monolith, that California is a huge, enormous landmass with so many people of different stripes all across the state, north, south, different challenges, and to have this opportunity to focus not just on the affordability word, but that value word, right? How do we make healthcare not cost an arm and a leg, but really impact all of our legs and arms in effective ways so that we can be a healthier population for all. So the chance to not just impact the discussions here, but to take the discussions that we have in this body and connect them to other discussions I have the privilege to be a part of, whether that's on how do we change the cost of pharmaceuticals in California, Two, how do we start paying for the social drivers of health in the Medicaid program? Those are, I think, really, it's a privilege to have this chance and be with this esteemed group of folks who I know are going to be mission aligned. And as we like to talk about the agency, put the person back in the center. I think sometimes we get away from being about the people of California. And I know this group, just assembling the team here, and with Elizabeth, your leadership, Vishal, your leadership, that's where we're going to keep our focus. So really a privilege to have this chance to be with this group.
Thank you. And I am looking forward to working with just a really talented group of fellow board members, as well as the staff at HCI. It's great to see David Carlisle, who I have not seen for many years. And Dr. Carlisle reminds me that in 1989, Alan Enthoven and I published an article in which we described healthcare as a paradox of excess and deprivation. And that was more than 30 years ago. And here we are today. On the deprivation side, as Elizabeth said, we have made progress. And I had the privilege of working in the U.S. Department of Health and Human Services from 2010 to 2016, along with Don Molds and others. And the great privilege of being a very small part of getting 20 million more people health insurance was by far the most satisfying professional work I have ever done. Medicare and Medicaid have, for, as we all know, at least some levers around price. Difficult to use those levers effectively, but also levers around regulation of health plans in some uniform way, and difficult to use those effectively, but at least there are levers there. The private sector historically has had no levers. We relied on competition among providers and to some extent among insurers to try to get better value and constrain spending growth. And I think we are all well too aware of the limitations of that mechanism. We see in California hospitals getting more than twice as much from private insurers as they get from Medicare for the same kinds of services and patients. And hospitals, given the cost structures they have, need that more than twice as much for the most part in order to stay solvent. But cost structures are not given from heaven. And it's also the case that there are quite a few hospitals in the state that routinely have operating margins of multiple hundreds of millions of dollars or more. So price is certainly a problem on the private sector side, and the authorities given to the board and the office at least provide some possibility of making progress there. And I think none of us are naive to the challenges in making progress. But I am excited about the possibility of working on that, as well as both Elizabeth and Dr. Ghaly have said, the tremendous problems of access to care for vulnerable Californians, the underinvestment in primary care and behavioral health care and prevention and public health. So with eyes wide open about challenges, I am very excited to be working with all of you and all of you on trying to make progress.
Thank you. I'm Ian Lewis. I am Research Director at the National Union of Healthcare Workers, and I'm also a trustee on a Hotel and Restaurant Workers Welfare Fund in San Francisco. I cut my teeth on health plan administration 23 years ago or so with a large union-sponsored fund in Las Vegas, and came to California about 20 years ago. And California's health system has many redeeming features: transparency, and affordability are not among them. In the 20 years that I've been working with the Hotel and Restaurant Workers Fund in San Francisco, a typical dishwasher or housekeeper in that city, if health premiums had only gone up at the rate of inflation, each worker in that plan would have $216,000 more in their pockets today or in their pensions today than they do. This health system, as many have observed, it's an unacknowledged tax, and it's a regressive tax on working people. So I'm so grateful to all of you who helped marshal the Office of Healthcare Affordability forward and to reality. I come to this with a real sense of urgency. That economic burden that it places on the state, the unaffordability that it places on our state, it handlocks workers into jobs they don't want. It binds employers and prevents employers from hiring the way they would like. And it has a real human cost. I witnessed this firsthand with the pandemic, having to handwalk tens of thousands of people off insurance and onto public programs for those who were eligible for them at the exact moment that people most needed their health insurance. And so I'm extraordinarily excited to realize OCA's vision as quickly as we can.
Well, good afternoon, everyone. I'm David Carlisle, and for the past 11 years, I've been president of Charles R. Drew University of Medicine and Science in Los Angeles. For the 11 years before that, I was the director of the Office of Statewide Health Planning and Development. And I just want to say thank you to Governor Newsom for asking me to serve on this distinguished board. Thank you to Secretary Galley. Thank you to Director Landsberg also for the privilege of serving, and everyone else. It's great to reconnect with colleagues that I've worked with for many years as we've pursued equitable health care and efficient health care in the state of California. If I may, I just want to tell a brief story. I'll keep it under 2 minutes, I think. So a while ago, one of our employees came to me and said, Dr. Carlisle, I think I'm having chest pain. What should I do? And I said, you don't want to really ask me that question because there's only one answer you're going to hear from me, and you know what it is. And she said, you mean I'm going to have to go to the emergency room? And I said, yes, you're going to have to go to the emergency room. I can't tell you what's wrong with your chest. Don't even want to. She told me a couple hours later, okay, I'm fine. They did an EKG on me, did some blood tests, saw a doctor. They said, it's not my heart. I said, great, wonderful. 2 weeks later, she came back to me and she said in tears, now what am I going to do? I have this $25,000 bill that the hospital sent me, and my insurance company tells me they're not going to cover it. And I said, don't worry, call the insurance company, tell them you want to appeal it, and a doctor sends you to the emergency room. She said, okay. She came back later and said, Dr. Carlisle, that's the best advice you gave me since you told me to go to the emergency room, because now I don't owe anything. My question is not why she got that bill of $25,000, but why a doctor's visit, an EKG, and a set of cardiac enzymes cost $25,000. That just doesn't make sense at all. But that's where our healthcare system is. And it's still true today, despite the great advances that we've made in our healthcare system in California. And they've been truly great advances. I mean, our work has been cutting edge, and we've made great progress. Congratulations. But it's still true today that a question that existed when I first started working in healthcare reform, probably 30 years ago, still is relevant today, which is how much of an illness can you afford? That's the paradox that we're facing in healthcare in California. People can't get care or don't want to get care. They don't go to the doctor because they're afraid of how much it costs. And that's a travesty, a true travesty. So I'm very happy to be here on this board because this is where we can do something about it. Again, I want to express my appreciation to Governor Newsom, Secretary Galley, Director Landsberg for the privilege. I'm looking forward to working with everyone else on the board. Thank you very much.
Great. Hi, I'm Don Molds. I'm the chief of the health program at CalPERS. CalPERS is the largest purchaser in the group market of healthcare in California and the second largest purchaser of group healthcare in the United States. We purchase healthcare for about 1.5 million, primarily Californians, although certainly folks who both employed outside of California work for California entities and retirees, so nationally and internationally. And that adds up to about 1.5 million people. One of the reasons that I'm here is that I was named in the legislation. I have no idea how that happened. We didn't ask questions, but certainly it makes a lot of sense as a purchaser of our size in California and purchasing for the folks who we purchase for. A second important reason is, it goes without saying, that healthcare affordability is absolutely critical for us. So we do a pretty good job at CalPERS. So I worked at the Commonwealth Fund for 5 years between the job that I shared with Rick, which was fantastic, and the job that I'm in now. And the Commonwealth Fund produced a lot of literature about the effects that cost sharing has on healthcare and health outcomes. And not surprising to anybody in this room, one of the first things that happens when cost sharing goes up is people defer needed care. It happens in the group market. It happens surprisingly frequently in Medicare. I think we're pretty good at CalPERS designing health benefits that minimize those kinds of trade-offs. But at the end of the day, we have a limited amount of money to work with to purchase health insurance. And when premiums go up, we see some of those effects. So it is not just not having the governor or the counties that we purchase for angry with us. It is also all about the healthcare of the people that we are purchasing for. Just as a sort of little bit of personal privilege on this, the other thing that I think about when I think about healthcare costs is the trade-offs that we make. You know, we need to remind ourselves that we spend almost 1/5 of GDP in this country on healthcare. We spend about half as much as other wealthy nations who spend about half as much as we do on healthcare. We spend about half as much on social benefits. So we have not made meaningful investments in housing in this country for 30 years. And a lot of that is because the money that would be going to that is spent on healthcare. And so we see that also not just in the homeless epidemic that we're dealing with right now, but also in health outcomes. So when you look at Americans and how their health fares in the system where we're spending a lot of money, the outcomes are inferior, and a lot of the reasons is that we can't support them in other ways. So right-sizing the health spend is important for a bunch of different reasons that I think we want to keep front of brain as we move forward.
There we go. Thank you. Technology. So I'm Dr. Richard Pan. I'm a pediatrician, health services researcher, and former state senator. And again, I first of all, I want to thank the Senate Rules Committee and the Senate Pro Tem, Tony Atkins, for appointing me to serve on this board. I look at it from a couple different perspectives. So first of all, as a pediatrician, I've devoted my career to helping children, a particular clinical focus on children with learning disabilities, behavioral issues. So a lot of overlap with both physical and mental health. I was previously at UC Davis, where I taught our future physicians about social determinants of health. How do we try to improve health outcomes, not just simply deliver high quality health services. Started a not-for-profit to get children healthcare coverage. Actually worked, while I was in residency, worked on a bill and actually a law in Massachusetts that was a forerunner to the SCHIP federal legislation. In fact, because we passed it in Massachusetts, then it was submitted to the US Senate by Senator Kerry and Kennedy, and then that became SCHIP. So I had that experience as well. but have basically during my career focused on low-income children, children who don't have insurance. In fact, I ran for the legislature because I saw my patients, many of whom lost their mental health services when, or had them delayed when the state, in its fiscal crisis, couldn't pass a budget on time, and basically cut off their mental health services or severely restricted them. And so those are my patients. I was also a medical consultant for my school district because I believe in trying to figure out how do we build healthier communities. It's not just going to happen in the office or the ER or the hospital ward. It's got to happen in the community. And so not only do I teach my residents that, I myself practice that way. In fact, after I got elected to the legislature, I continued to volunteer at a community health center. I tell people in the beginning of the week, I shaped the rules as a legislator. At the end of the week, I live by them. And I had to look my patients straight in the eyes and say, okay, this is why the Medi-Cal program is or is not working for you. So I'm bringing that perspective to this. Certainly, I appreciate the honor and privilege of being able to serve in the legislature to actually work on this legislation. Now, I was fortunate enough to come in when I could actually play a leadership role in ACA implementation, worked on getting Covered California stabilized when they were trying to stabilize that, expanding coverage for people for undocumented Medi-Cal. In fact, I like to say that when I came into the legislature, actually I think it was 18% uninsured in California at the time. You talked about 22, I think it was 18. And I think the estimate is that obviously we don't have the exact number yet for 2022 when I left, but it's probably going to be between 7 and 8%. So still a ways to go. But we've made significant progress in getting people insurance coverage. I should also make note that I appreciate you talked about your experience with, I think, Unite here on their board, because I helped with legislation. It was actually authored by Senator Leno, but I was the floor jockey in the assembly to try to increase transparency so that the Unite Here union could actually have the information they need to have to basically not only negotiate lower rates, but also help their members be healthier, right? So they would have the information that the health plan had that they didn't have to help try to encourage that. So that, and then in exchange could then say, look, we can get lower rates if we can create healthier environments, do health education, other types of things. I mean, that's what we got to think about. How do we spend smarter, right? So from my perspective, it's about, sort of the triple aim or quadruple aim, right? It's not about trying to make health spending just down, but what is the right amount, right? And are we spending it well? I really do appreciate that, and all the folks many of who are in the room, many who are not, who worked on this legislation. I was proud to include the provisions on the equity in that. I think it was the Senate who asked that be put in, because I think as someone who basically still spends my time seeing kids who are children who are coming from more disadvantaged populations, who are in under-resourced communities, equity is extremely important. We see that those inequities lead to poor health outcomes. And the other observation I guess I'd also make is that during the entire discussion, both about this bill and others, I haven't heard someone come around and say, oh, we need fewer healthcare providers. Everyone's saying we need more. We need more behavior. In fact, appreciate the governor's leadership in funding more training we need more. We need more. In fact, we see right now, we have shortages of various health, both in behavioral health, nursing shortages, et cetera. And we're going to have to wrestle with the impacts, what that means, right? Because you're not going to hire more people with less money. Right. We also have to think about COVID and its impact, its long-term impact. So it's not going to be a straight trend line from before COVID to now. COVID with long COVID, with the mental health, the changes in mental health, other types of things. We are going to have to figure out how to incorporate that to be sure people actually get the care that they need. So, right, we have to figure out how to right size. And I heard that from many of the other members of the board. So I'm very much looking forward to working with all of you, with the various stakeholders that are here who both worked on the legislation. And now, of course, frankly, the reason I asked to serve on this board, and I appreciate again the Senate appointing me to the board, is having worked so hard on this legislation, I wanted to be sure we saw it through and it got it implemented correctly. So I look forward to working with all of you in making that happen. Thank you.
but my button wasn't pushed, so she couldn't hear me. Sandra Hernandez, we're very pleased to have you introduce yourself if you would be so kind.
Thank you. Thank you very much. Good afternoon. I regret that I couldn't be with you all in person today, but I look forward to being in the room with you at our upcoming meetings. I too want to appreciate the governor for appointing me to this board. I think it's an incredible honor, but also an incredible responsibility and opportunity. Not unlike Senator Pan, former Senator Pan, colleague Dr. Pan, I'm a primary care trained internist. I came to California many 30 years plus ago to work at one of our safety net hospitals, which really just took care of Medi-Cal patients and largely a large population of uninsured folks. And really over the 30 years as a clinician doing outpatient work in HIV during the pandemic and epidemic of HIV, we've seen the struggle to both get everybody covered, well on our way, as others have said, in that effort. And yet affordability really remains a significant barrier, as everybody's mentioned, as Director Landsberg in her remarks mentioned. I look forward very much to working with my colleagues on the board, to working with our advisors who will be advising us, and really the general public. Our efforts in methodology and in setting targets will be better with also recognizing that there are many considerations that need to be taken into account. And so I really look forward to a robust stakeholder engagement process. And as others mentioned, I think the challenge for us, other states have taken this on and made good progress. None of them, I think, with the keen focus on health equity and really achieving the goals that we need to achieve around making care more affordable, but doing so in a way that also accelerates our effort toward a more equitable healthcare delivery system. So I'm quite honored to be with all of you. I look forward very much to working with my colleagues and with you, Director Lansbury, and your team. And I'm looking forward to the rest of the meeting. Thank you very much.
Thank you so much. Okay, with that, we're going to move into some context for the Office of Healthcare Affordability. Actually, we're going to do an HCI overview very quickly first. So the decision was made by Secretary Ghaly and others to place the Office of Healthcare Affordability at what was then OSHPD, and partly because we were growing with the added portfolio of the Office of Healthcare Affordability. We graduated from an office to a department. So OSHPD was formed in 1978, as Dr. Carlisle noted, as the Office of Statewide Health Planning and Development. And we have had our name change and our recast in 2021 to acknowledge our growing portfolio. And we think the name does a good job, hopefully, of capturing the work that we are doing. So the next slide includes our mission, which is to expand equitable access to quality, affordable healthcare for all Californians through resilient facilities, actionable information, and the health workforce that each community needs. And I'll just go through our 5 program areas within HCI and talk a little bit about some places where we think there are some important synergies between the work that we're doing in some of our other offices and with the Office of Healthcare Affordability. So all of the components of what we're in OSHPD continue to be within HCI. So on the facility side, we continue to be the building department for hospitals and skilled nursing facilities in California, monitoring construction, renovation, and seismic safety. On the financing side, we have a small but mighty Cal Mortgage program that provides loan insurance for nonprofit healthcare facilities that are going through renovations or making other changes. And we are just starting a new small and rural hospital relief program, which we're excited about. On the workforce side, Dr. Pan noted the really workforce crisis that California and many other states are playing. And so this agency, this administration has invested as never before in trying to make sure we're supporting the healthcare workforce, specifically primary care and behavioral health. And we have three main goals with our workforce programs: to increase the racial and linguistic diversity of the workforce, to develop a workforce that serves the medically underserved areas, and to make sure we have a workforce that serves Medi-Cal populations in particular. And so again, unprecedented investments and innovations in healthcare workforce, everything from community health workers and promotores to doctors and psychiatrists. On the data side, if you're a researcher, hopefully you've used OSHPD data. We have patient outcome data. We have emergency room and inpatient data, a lot of hospital and SNF financial data, and we are building California's all-payer claims database, which we call the Healthcare Payments Data Program. There's going to be some important synergies between OCA and HPD, or all-payer claims database, which will be substantially complete and start with public reporting this summer, which we're incredibly excited about. And so as the Office of Healthcare Affordability identifies cost drivers and we want to better understand those cost drivers, the all-payer claims database data will be critical in doing that. There's also some important synergy with the workforce areas. As when Deputy Director Pagani goes through the overview of the Office of Healthcare Affordability, one of the components is around measuring workforce stability, and so we'll have some good collaboration there. And then we're very pleased to add this fifth area around affordability with the launch of OCA, with the incredible work that Dr. Galley and Vishal and the governor have been doing around having California manufacture our own biosimilar insulin products at a transparent, affordable price. And so that was a very exciting announcement on Saturday. And these gentlemen get a lot of the credit for that wonderful work. And then we're also standing up at HCI the hospital fair billing program. Some of the experiences folks have had around hospital billing. So we're pleased to have our first consumer-facing program around hospital billing. So that is an overview of our HCI program areas. And now I will move on to some of the context. So I don't think anyone in this room disagrees with the supposition that healthcare is unaffordable in California, and yet we think it's very important for us to ground ourselves in some of the data as we move forward to do this work. So you all will be developing a methodology around slowing healthcare spending growth. And again, we want to make sure we have a common understanding of the rationale for doing so. And Don Molds could probably recite all this data off the top of his head. So our next graph shows how much of the United States has spent on healthcare, from 7% of GDP in 1970, increasing, really tripling, and you noted this, tripling to almost 20% of GDP in 2020. And I think it is important to note that those are all dollars. People have talked about those dollars not being able to go to wages. Those dollars aren't able to go to fund education and housing and many other priorities that we have. Compared to other wealthy countries, so this slide, I believe, has 11 different countries, and the United States spends more per capita than any other similarly situated country, and we are getting worse health outcomes. So it's very striking to look at these numbers and see by how much more, our per capita is, Germany is the next closest at 6,000, and we're at 10,000. So it's very significant. And we'll look at some measures showing the worst health outcomes in the United States. Moving to California specifically, here we see average healthcare spending growing from about $2,600 in 1991 to more than $10,000 per capita in 2020. So we have seen, as noted on the slide, a 4.8% annual growth rate during these 30 years. And we've seen per capita spending quadrupling. But as noted, wages have only kept pace with inflation. So between 2010 and 2018, wages and inflation grew cumulatively by 20%, and during the same period of time, healthcare spending grew by 40%, twice the rate. So Ian talked about the impact that this has on wages, on negotiations, and what employers are able to offer. The next slide, again, sadly, this is not an area where we want to be at the top, but we have the second highest average annual % growth rate in spending on the commercial side. So our average annual % growth rate in per enrollee healthcare spending for those privately insured is at 5.1%. So we're very much an outlier in the country in terms of how much spending is increasing. And then very much we see that California workers bear the burden of these increasing healthcare costs. So to look at the rising spend in healthcare in California, this graph shows small business premiums for Californians increasing by 65% since 2011, with the amount attributed to the employee share premium growing by 133%, right? So we're both seeing the cost of coverage increasing, the cost of premiums increasing, and the percentage of that increase being shifted to the workers, to employees. It's not just premiums that have increased dramatically. Part of the cost shifting to consumers is through plans with higher and higher deductibles. So here we see the growth of family deductibles, which have quadrupled in the past 2 decades. So the yellow line is the employers, the smaller employees with less than 50 employees, and they saw a 10% annual growth rate. And you know, we've seen this in many plans. And then employers with 50 employees or more, the larger, are represented with the gray line, and they saw a 9% annual growth rate. And I think we're all aware of the impact of increased deductibles, and that's where people do hesitate to get care that they need because they are so concerned about the cost. So some preventive care is first dollar care, and you may be able to go to your primary care physician, but you may not be able to get the drugs that you need and some of the diagnostic and other specialty care that you need with those high deductibles. So again, we talked earlier about how the United States sadly is spending the most, but again, very important to note that we're spending the most with with worse health outcomes. So that increased spend does not translate to better outcomes. And I think this is a pretty devastating slide. So across many health indicators, the US has worse health outcomes, and this focuses specifically on infant mortality and maternal mortality, where we have by far the highest infant and maternal mortality compared to other high-income countries. So to look at that those maternal death rates, where we are more than double the average of these countries, and of course we know it is much worse for Black mothers and for Black babies than for other Californians. Okay, so this is very recent data that the California Healthcare Foundation has been putting out, showing that the high costs, you know, they're going directly to consumers. So many of us have stories. This is a survey of many consumers showing the high number of folks who are skipping care. So more than half of Californians are skipping or going without care because of the high cost. And on the right, we see that it's more than 2/3 of low-income Californians are skipping and going without care. And then the green bars show the impact that more than half of those believe that it has had a worse health outcome. High costs for healthcare disproportionately affects Black and Latinx Californians, with 36% and 40% respectively reporting that they had problems or were unable to pay medical bills. Black and Latinx residents are also more likely to skip care due to costs. So we can see in the orange and gray bars the much higher rates for Black and Latinx consumers who are going without care specifically because of cost, and of course many to very detrimental impact to their health. And, I've certainly seen this personally. I'm sure many of you have also that the high costs actually can contribute to personal bankruptcy. So I talked earlier about the fact that I started my healthcare career at Legal Services of Northern California at the Health Rights Hotline. Reliably, at least a third of our cases were medical debt cases. So, many of them were folks who had gone to the emergency room, got bills. Some of them were for specialty care, the surprise billing, and we've come a long way in California with AB 72 and other provisions to try to address that. But we still have many too people with medical debt and with personal bankruptcy. So this gives us data both nationally and California of the percentage of folks who have medical debt. Even as we've done this coverage expansion with those high deductibles, we still see a lot of people with high medical debt. And last, this slide, this graphic medical, this shows that graphic medical debt is more prevalent in communities of color as compared to white communities. So again, I know you all know some of this data, but I think it's important to ground ourselves in this context. And with that, it is with it's a great privilege to turn it over to Vishal Pagani, and very few people have done as much work to launch the Office of Healthcare Affordability as Vishal has, but I see that Dr. Pan has a question.
Thank you. And thank you, Director Lansbury, for your presentation, and sorry to interrupt. I did want, and as someone who was former chair of the Asian American Pacific Islander Legislative Caucus, you did present data where you showed Asians, but I think we need to recognize that if you don't disaggregate the data,
Yes.
You're masking a lot of disparities within there. So I definitely want, because you had several slides where you had that, and I think it's important we need to point that out. So I'm sorry I couldn't let that pass, but I wanted to point that out. And so again, appreciate your presentation, but I just also want, because we didn't make reference to that. So thank you.
Thank you very much, Dr. Pan. It's a critical point. And so we took data that was presented, but absolutely more and more departments are not just
Right.
rolling up Asian Pacific Islanders, and we do need to look at the disaggregated data. Thank you very much.
Yeah, especially, and then also if the surveys are being done only in English, we're actually losing respondents who actually are probably more disadvantaged because of language barriers, but thank you.
Thank you very much.
Thank you, Director Landsberg. So I'll be going over the enabling statute, its key provisions, as well as board roles and responsibilities. Next slide. So just want to give everyone a rundown of the terminology. There's going to be many ways to describe spending target programs. Some states use the word cost growth benchmark. Some states call it a cost target. Some call it a benchmarking program. Here in California, we're going to be using the word spending target as well as describing spending growth. But in terms of like cost target, we may use that term sometimes, but our preference is to describe it as a spending target. Next slide. So to set kind of the national context, this map shows the number of states that have implemented spending target programs. California has joined 8 other states. The furthest along is Massachusetts with their Health Policy Commission. With California's entry as the biggest state in the country, it's estimated that 1 in 5 Americans now live in a state with a spending target program. Because we weren't the first state to do this, we had the privilege of learning from other states, looking at other innovative models and policies, and crafting an approach that's distinctive for the way our program here is comprehensive and also for its enforceability provisions. Next slide. So if we were to bucket the statutory activities of OCA, they would be to 1, slow spending growth, 2, promote high value, and 3, to assess market consolidation. Next slide. So in terms of slowing healthcare spending growth, the office will collect, analyze, and report data on total healthcare expenditures. So this is another acronym that we'll be using quite a bit, THCE. The office will develop a spending target methodology that considers economic factors such as GDP growth or population-based measures such as changes in demographics, and set a numerical value for the spending target. Initially, there will be a statewide target for calendar year 2025. By March 1st of 2024, the office will announce a proposed target. The board will have until June 1st of 2024 to approve the target. I do want to note that the first target for 2025 is a reporting year only, and the first enforceable target is for calendar year 2026. Eventually, the office will set sector-specific targets. So sectors, it's not defined in the statute, but it does have some guidance in terms of the types of factors that could be looked at. Sector-specific targets could include geographic regions, certain types of entities, or fully integrated delivery systems. And then lastly, in terms of the tools that the office has for enforcement, it is a progressive enforcement approach. First, it would begin with technical assistance to find out what happened, sitting down with the healthcare entity to understand why they may have exceeded the spending target. The next step would be compelling public testimony at a public meeting of the board. The office could also engage the healthcare entity in a performance improvement plan where they would identify strategies to reduce spending growth while maintaining the quality and equity of care. And as a last resort, the office does have the authority to assess financial penalties. Next slide. So in terms of the types of healthcare entities that are subject to the spending target, there's three categories: payers, providers, and fully integrated delivery systems. The latter category for what we're calling FIDS, the only entity that meets that definition is Kaiser Permanente. For the other categories, it does include the typical entities you would expect, such as health plans, and then for providers, it includes medical groups, hospitals, and clinics and other types of outpatient facilities. Next slide. So in terms of activities to ensure a balanced approach, because the office would not focus just on costs alone, but really driving towards greater value in the healthcare system, there's a series of activities included in the legislation. The first is to track quality, equity, and access measures. We would leverage existing measures that are currently being used, whether they're reported to state programs or other quality improvement initiatives. The office would also set benchmarks and report on primary care and behavioral health investment. These two services have been linked to, spending on these two services have been linked to not only better outcomes for consumers, but also savings to the healthcare system. The office would also set benchmarks for the adoption of alternative payment models or value-based payments and report on progress. So the intent of this is to track the progress of the shift from fee-for-service payments that may be linked more to volume of services delivered, and track the progress to value-based payments that are linked to quality and cost. And lastly, the office also has responsibilities for promoting workforce stability to ensure that cost targets are not achieved to the detriment of frontline healthcare workers. So overall, with the inclusion of these set of activities, as we mentioned earlier in this meeting, the intent is simply not to have a low-cost system, but to take the best ideas and reorient the healthcare system towards greater value. Next slide. The office will also engage in market oversight activities to partially fill the gap for mergers and acquisitions that are currently not being looked at. The office will receive notices of prospective changes in ownership, operations, or governance for healthcare entities. So when I say partially fill the gap, there are existing regulators like the the Attorney General's office that looks at nonprofit health facilities, when we have the two insurance regulators for DMHC and CDI. So the intent here is for the office to look at transactions that aren't being picked up by those existing regulators. So if a transaction is likely to have a significant impact, the office would complete something called a cost of market impact review, or CMIR. The CMIR effectively assesses whether the proposed transaction is in the public interest, in terms of it being good for competition, that whether the transaction could impact the ability of the state to meet spending targets or affect affordability for consumers and purchasers. So during this assessing of market consolidation, the office would also work with other regulators, such as the Attorney General's office, to address market consolidation. I'd also note that OCA does not have the authority to block a transaction, but does play an important role in increasing public transparency for transactions that currently aren't being looked at today. And sure. Yeah.
There you go. I was going to ask a question. Actually, two questions. Sorry. First question is, can you describe a little bit the sort of the division of responsibility between the Department of Justice, Attorney General's office, and the Office of Affordability? So, what you just described is pretty similar to the review they do. How does it differ? How are they coordinated, and so forth? And then the second question is it does the legislation speak to our ability to weigh in on? There's going to be legislation on this again this year, but is it appropriate that we weigh in on pending legislation or not?
Regarding your first question, the OCA staff would be coordinating with the Attorney General's office to the extent that it's doing an analysis of a proposed merger and transaction, and if it does need to hand it off to the Attorney General's office for further review, there will be coordination with the Attorney General's office as well as with the DMHC if it involves a healthcare service plan. So in terms of the review, it is similar because we are looking at the effects on market competition, and the Attorney General's office. Their authority is primarily limited to nonprofit health facilities, but there are currently like for-profit health facilities. That's a gap in California's regulatory structure, so OCA would fill that gap. And then regarding the second question, I'll turn it.
Yeah. I guess we could cross that bridge when we got to it if the board was interested in taking a position. I mean, it's not something it's specifically outlined in the statute, and HCI, obviously has our own process for legislation.
Michelle, could I ask a question as well? Just going back 2 slides to the healthcare entities subject to the spending target slide, it lists in the middle rubric under providers, physician organizations, health facilities, et cetera. Is there enough flexibility in the legislation for a health system to be a covered entity, or is that not possible? I mean, increasingly, as you know, in California, care is being delivered by providers who are part of health systems, meaning some organization that owns a whole, number of other providers. And can a health system be a covered entity?
I would say that the health system would fall under the health facility, because if it does kind of have a hospital at its center, it would meet that definition in the second bullet.
Yeah, and I would also say the definition of physician organization is quite broad. So yes, health systems are covered entities. What?
If I recall correctly, I think there is a provision in the legislation related to value-based care. So I guess depending on the nature of the relationship, et cetera, I think there was certainly, there's maybe opportunities to say that as a package, right? Because instead of trying to disaggregate, take apart an integrated piece. So, but that's certainly something I guess we can discuss and explore. I think there was some discussion about that.
Yeah, just for this kind of agenda item, just have a few more slides. Next slide, please. So, by virtue of having this meeting today, we have a fully named board. We're very excited about that to start the important work. So this slide just lists the differences between the board and the advisory committee. A few distinctions I'd note are the board is a decision-making board that will set spending targets and approve key benchmarks such as APM adoption. The board will also appoint an advisory committee. The board also cannot have members that receive compensation from healthcare entities. And then because the office needs to receive feedback and input from the industry, there is a separate advisory committee that will make recommendations. As you see here, the advisory committee has a wide-ranging set of stakeholders, including health plans, providers, and consumer advocates. And both of these bodies would be subject to the Bagley-Keene Open Meeting Act. And then next slide. So in terms of key milestones for 2022, the office has made good progress in hiring its leadership team. It's including 3 assistant deputy directors. To support our planning, we've brought on expert consultants to quickly stand up the office as we hire staff. For 2023, now that we've convened the Healthcare Affordability Board, one of our first tasks will be to support the convening of the advisory committee. A key activity that OCO will support the board on is the development of the spending target methodology. So this essentially entails a series of design decisions on how to measure spending. During 2023, we'd also work on regulation packages for data collection, as well as the notices I mentioned of proposed transactions. We'd also begin work on the primary care and alternative payment model adoption components. For 2024, we'd set the cost target for 2025 based on those March, June timeframes I mentioned earlier. We'd also begin collecting some initial data for 2022 and 2023. And we'd also begin receiving our first notices of proposed transactions. Next slide. So, this slide illustrates how enforcement could work for the first statewide spending target. The first enforceable year is 2026. In the blue box on the right, you'll see a stepwise approach for enforcement, beginning with technical assistance and ending with financial penalties. As I mentioned earlier, we do have that March, June timeframe. So in 2025, March of that year, the office would put up options for a proposed target, and then the board would finalize it by June. It does take some time to get the data, so we have to wait for the calendar year to close and for the data to settle. So it'll be a good 6 to 9 months after 2026 where we would receive the data. We would analyze the data, and then we would report on calendar year 2026 sometime in 2028. And then based on the performance of healthcare entities, we would begin the progressive enforcement process. Next slide. So the next slide just covers some resources for interested stakeholders. We do have an OCA inbox that's listed there. Encourage everyone to subscribe to our listserv if you haven't. That's the way we'll be pushing out information. And then we have a landing page describing OCA that includes resources there as well. For the next item, this is the agenda item for, yes.
Need to turn on your mic.
I think you may just need to speak a little louder. Is the green light on? Okay, thank you.
Yeah, yes, the statute says that as well.
Thanks.
So I'll be covering doing a high-level review of board roles and responsibilities. So the statute uses 4 terms when describing various activities. These terms are approve, establish, consult, and discuss. I do want to note that approve and establish are fairly similar in their effect, but established is used more specific to the board's role in setting spending targets and their value, numerical value, and also setting definitions. For the approve activities, one of the first actions by the board will be to appoint the advisory committee. The board will also need to approve a methodology for setting and modifying spending targets, which may include periodic updates or adjustments based on various factors. The board will also approve benchmarks for alternative payment model adoption, primary care and behavioral health investment, and workforce stability standards. I also want to note that for spending target enforcement, the board would set policies for administrative penalties, including the size and including the scope and range of administrative penalties. But the office would be the entity executing the enforcement action. Under establish, the board will set the statewide target and in future years define sectors and set specific targets by sectors. As the office gains experience, the board would also have the authority to set standards for that need to be met for exemption from targets or submitting data directly to the office. For consult, I'd call out that the board will be consulted on risk adjustment and equity adjustment methodologies. The board will also be consulted on performance improvement plans during closed session. So the next 2 slides will go over various activities related to board discussion topics. These include activities in terms of the office leading discussion topics with the board. These include options for spending targets, collection, analysis, and public reporting of data, analysis of drivers of spending growth, strategies to improve affordability for consumers and purchasers, and addressing the role of consolidation and market power on healthcare spending. Next slide. So we want to note that all rulemaking packages will be discussed at a public meeting of the board. In addition, the office is committed to engaging stakeholders on rulemaking, including workshopping as necessary. I will note that the statute does not require the board to approve the regulation text, but the office is required to present regulations as a discussion topic for the board. Lastly, the board will discuss the baseline report, which will cover data for calendar years 22 and 2023. Once the spending targets are in place, the office is tasked with producing a more detailed annual report, which will present on healthcare spending trends and analysis of cost drivers. The first annual report will cover 2024 and 2025. This report will also include policy recommendations for managing spending growth, improving the quality and equity of care, and promoting workforce stability. And I'll turn it back over to Director Landsberg for our next agenda item.
Thanks very much, Vishal. I want to make a note that we have put together a board manual as a reference, and if any of you have questions about that, please reach out to Megan Brubaker with any questions. And with that, just want to see if there are any questions from any members of the board about the board orientation items that we've covered thus far before we move to public comment. Okay, so we will take public comment on this board orientation agenda item, and again, we'll also take public comment on other items. Ms. Capel.
If I could say just a few words to orient people as well,
Yes,
Director
thank
Landsberg. Thank you. So as you mentioned, we will now recognize members of the public to give comment on items, agenda items 1 and 2. We'll also be inviting comment during the election of the chair segment, and we'll open it up to general public comment at the end of this meeting. To ensure equitable access to verbal public comment, we'll alternate between members of the public who'd like to speak in this room and those who are virtual. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. For those giving comment in the room, you have this nifty countdown clock, and I will let all speakers know when they have 10 seconds left. If you're interested in speaking during this segment, if you could line up behind the podium, but perhaps along the window so as not to block the view. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise their hand. It will track the order in which hands were raised. During the public comment period, remote speakers will be unmuted when it is their turn to speak. We also invite you to provide written comment at oca@hchi.ca.gov. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that's not included on the meeting agenda, except to place the matter on a future meeting agenda. All right, we'll start with our first speaker here at the podium, and then we'll move to virtual speakers. Thank you.
Beth Capel with Health Access California. Thank you for the opportunity for public comment on this item. We are very pleased to be here on this day. It has been, as a number of you noted, a long journey to get to this day, and we are very pleased to see the board that we are speaking in front of and respect the expertise that you all bring and the background. We want to thank the governor and this administration. The governor made this his own proposal, and we very much appreciate that. And we also appreciate the investment of both houses of the legislature in making this happen in the way that it has happened. And we also want to thank the staff of HCI for the presentation today and for providing it in advance. We also want to acknowledge that we have a few friends here and on the line from Unite Here Health and SEIU and other organizations that have also pushed for many years to address the issue of healthcare costs. We want to begin by saying, in terms of the substance, that consumers pay for increases in healthcare costs. We pay directly in terms of premiums or share of premiums, cost sharing, copays, deductibles, coinsurance. And we pay, as you have also heard, indirectly in terms of suppressed wage growth over the many years. Wages have grown more slowly than state gross domestic product or inflation. And in part because of the growth of healthcare costs. We also want to note that every increase in healthcare costs worsens the income-related social determinants of health. And I want to put it in that frame because I know we are all concerned about equity. For the lowest income, higher healthcare costs means food insecurity, housing instability, inability to afford utilities and transportation. For the middle class, higher healthcare costs mean more medical debt, seeking less care, less ability to afford whether it's the kid's college education or retirement. All but the most affluent are affected by higher healthcare costs. We would also note, as your presentation did, that the United States and California have the most expensive healthcare systems in the world, and yet we get less care, fewer doctor visits, fewer hospital days, and you heard a small subset of the examples where we have worse outcomes. We ask that this board and this staff ground their work in the impacts on consumers at different income levels. $1,000 or $2,000 deductible affects somebody making $30 or $40 or $50,000 very differently than somebody making 2 or 3 times that amount. And so we ask that you think about that as you think about the work of affordability. We also note, as your presentation did, that we begin at a very high base in terms of healthcare costs. It's not just, as Kronik noted, that, and as we learned from him, that hospitals get paid about twice as much by commercial insurers as they do by public programs. There are hospitals in California that get paid 400 or 450% of Medicare and charge far more than that. And the hospitals that get paid the most tend to do the least in terms of Medi-Cal. And I'm sure Dr. Pan, reflecting on his own experience, would see the same thing happening for physicians. We look forward to working with you, and we are going to keep coming back to this because whatever the spending target is, whether it's 3.1% or 3.6% or some lower number as some other states have set, every dollar in increases comes out of the pocket of consumers one way or another. And so for us, we will be here reminding you of that at every step along the way. And thank you. We'll look forward to talking with you further.
Thank you. Turning to our first virtual speaker, I'll let you know when you have 10 seconds left.
We are not seeing any raised hands virtually right now.
Okay, great. We'll turn to the next person in the room. Thank you.
Thank you, members of the board. My name is Hector Aspelcueta, and I'm the head of the local union in the Monterey Peninsula, Unite Here, Local 483. I am also the chief negotiator for 1,500 members in 12 different hotels in the area. I'm also a trustee for a Taft-Hartley Health Fund, and I have done at least 3 rounds of negotiations in the last 10 years. As you know, Monterey Peninsula seems to be an island and is one of the most expensive areas for hospitals. Due to Monterey County having the most expensive hospitals in the state, not just in the Monterey County, we are paying more than 20% into the health fund to maintain the same level of benefits that we have had for a long time. And this is just for the period of 2015 to 2021. And what we are looking at for 21 to 2026 is going to be almost double that to almost 46%. So that's a huge increase for us. The way we negotiate the contracts is something that we call a bucket money, which employers give a certain amount of money and we distribute it between wages, health insurance, and pension and other benefits. Most of that money ends up in health insurance. So these increases basically reduce the amount of wage raises that our members could have had to survive in the Monterey Peninsula. As probably you know, the Monterey Peninsula, the Central Coast, is one of the highest expensive areas in the state. And those hospitals are probably the most expensive in the state. The ever-increasing hospital costs will continue to burden our members and hospitality workers. While we pressure employees to pay more as much as possible, is never enough. They also have more operating expenses due to the healthcare costs. On behalf of the Monterey County hospitality workers and their families, please hear our voices and do what you can to get those hospitals costs under control. Thank you very much.
Thank you very much.
My name is Marissa Bell. I am going to be translating for Clementina, and then I will be going as well afterwards.
Buenas tardes, mi nombre es Clementina González. Hice un viaje de 3 horas para venir acá para contarles sobre mi experiencia con los hospitales del condado de Monterrey. Soy recamarera del Monterrey Thai Hotel, miembro de la Unite Here local 483, vivo en Marina. Hace alrededor de unos 10 años, yo fui al Hotel Comunitario de Monterrey para recibir tratamientos por problemas de salud que tenía con la sangre a raíz de un tumor que tenía en el útero. Era vital para mí ir de emergencia, que evitaba los hospitales, pero era vital para mí ir a los hospitales. Por muy caros los quería evitar. Recibía transfusiones en Monterrey Community Hospital y incluso que el seguro pagó la mayoría de las cuentas, pero a pesar que el seguro pagó las cuentas, me salieron alrededor de más de $10,000 hace como unos 10 años. Hicimos todo lo posible para pagar el hospital. Debía unos pocos meses, pero nos dieron unos pocos meses, pero no pudimos hacerlo de manera oportuna. Porque ellos tienen agencias de cobros. Y nos presionan a pagar. Ya cuando no podemos pagar ese tiempo, pues ya los mandan a colección. Mi familia y yo estábamos muy desestresados y deprimidos. A medida que reducimos los gastos en la casa, como gastos de alimentos alimenticios, empezamos a gastar menos, a comprar menos. Luego mi crédito empezaron a afectarlo hasta el día de hoy. Durante este tiempo se suponía que mi hija iba a egresar a la universidad, pero desafortunadamente no se pudo por mi condición de salud, porque me tenía que cuidarme. Ella hizo grandes sacrificios para ayudarme. En los últimos meses, la enfermedad fue progresando. Sabía que el hospital comunitario es muy caro, so que decidí seguir en otro hospital que es el de Natividad en Salinas, supuestamente que era más barato. Pues me equivoqué, ya que era tan caro como el CHAMP, como el Community Hospital. Mis facturas fueron pocos de miles de dólares. Mi esposo y yo estábamos tratando de devolver y pagar esas cuentas. A pesar que el seguro cubrió la mayoría de los gastos, estamos nuevamente muy preocupados. Por favor, hagan algo para que puedan reducir los gastos de los hospitales. Trato de evitar ir a los hospitales, pero me enfermo seguido. Tengo que hacerlo. Sin ese tratamiento, mi salud decae. Pues hace 8 años, a raíz de eso que decaí, me hicieron una operación que me costó $90,345.
Thank you.
Y yo tuve que pagar de ahí $2,000. Y ahí te voy haciendo con tantas las emergencias que fui a los hospitales. Gracias por escucharme.
Gracias.
Good afternoon. My name is Clementina Gonzalez, and I made a 3-hour trip here to tell you about my experience with a very expensive hospital in Monterey County. I am a housekeeper at Monterey Tide Hotel and a member of Unite Here Local 483, and I live in Marina, California. About 10 years ago, I went to a community hospital in Monterey for treatment for a blood alignment. I was hospitalized, received transfusions, and other procedures. Even with the health insurance that I had to pay over $10,000. And I don't have that. We tried our best to pay the hospital with what was within the next few months in a timely fashion. We tried our best, but the hospital sent us to collections. Ruined my credit. My family and I are very stressed and depressed. We had to cut back on food and other needs just to pay these bills back. During this time, my daughter was supposed to start college, and she decided to stay home for a couple of years just to take care of me. She made a big sacrifice for her, just for my health. In the past few months, the illness became bad again. Within the next few months, the illness became bad. I thought maybe the community hospital would help me. I thought wrong. It was just as expensive as CHOMP. I was billed more thousands and thousands and thousands of dollars just to keep me going. Even though my insurance did cover some of the bills, I'm now in debt again, and I am worried. Please do what you can to lower these hospital costs. I tried to avoid going to the hospital, but I'm too sick sometimes and I need treatment. Monterey is a very expensive place to live, and these hospital bills are just as expensive. Please do what you can to help people just like me. Thank you. Now I'm going to say my story. That was Clementina's. First and foremost, my name is Marisabel Luna Olmedo. I am a researcher for Local 49. So just want to start off by that. And for me, healthcare costs are very personal. I want to start off by saying everyone deserves access to affordable healthcare. Everyone. I grew up seeing my mom get poked and prodded, taken away by ambulances more times than I can count. After a total of 7 surgeries, 8 hospital stays, endless therapy appointments, 6 MRIs, countless ER visits, and so many prescription bottles, my mom is still here today. Whew, excuse me, I'm sorry, it gets a little personal after a while. But here's the reality of the situation. My family has been through hell and back, just trying to take care of her, to have her be here, standing here today. We were fortunate enough to have insurance through my dad's job, and we were able to afford our copays and deductibles. But then my dad got laid off, and we had to go on to Medi-Cal. Here's the reality. Having to convert to Medi-Cal opened up my eyes to how broken the system is. The quality of care that my mom was receiving decreased, and my mom's health declined. Adding everything up, all the medical attention that's needed to keep my mom alive has costed up to $250,000. $250,000 for one human. That's crazy. It takes average Americans, 7.5 years to make $250,000. That's wild. At my entry-level minimum wage retail job, I didn't qualify for Medi-Cal. I qualified for Covered California. Well, I decided to go see a doctor, and I was charged $428 just for a basic checkup and blood work. How is that affordable? That is not. The system that we have set in place in 2023 is not set in place for working people like that are behind me. We need to do better. We need help. And you guys have the power to be able to assist us. What are you guys going to do with that power that you have? Thank you.
Thank you. We actually have some members of the public virtually who would like to speak, so I'm going to turn to the virtual podium next and then back to this room.
Thank you. Go ahead, Carmen.
Good afternoon, everyone. This is Carmen Comsey with the California Nurses Association. It's nice to see some of my fellow Healthy California for All commissioners here on the OCA board. CNA wants to express our thanks to the board, and we're looking forward to the work that the board and the Office of Healthcare Affordability will be doing in the years to come. In the work of the OCA board moving forward, CNA wants to emphasize that healthcare affordability always consider affordability for patients, and that OCA and its board ensures that any attempts to reduce healthcare costs is not shifted onto patients and not shifted onto healthcare workers. In the meetings moving forward in the years to come, we must always ensure that patient affordability is in the forefront of discussions, and that there's some concerted criteria of the board on the impact on patients in terms of out-of-pocket costs, co-pays, deductibles, co-insurance, and so on. Patients' voices and stories should remain at the forefront, like the ones that you just heard on the board's work, and discussions of healthcare affordability must continue the discussions that we've had previously throughout the state, including the Healthy California for All Commission, on ensuring health equity for all Californians by eliminating financial barriers to care and ensuring that there are no insurance barriers to care. Additionally, we want to ensure that the board always consider how changes in spending targets and alternative payment models may impact access to care and the potential for reduction in care as a result of changes in the behavior of providers and insurers in authorizing that care. Finally, we urge the board to consider the impact that changes in payment models and spending targets have on the healthcare workforce, and that healthcare workers aren't being pushed to work in crisis standards, short staffing, or other reductions in workplace health and safety measures. Thank you, and we look forward to working with you all in the years to come.
Thank you. All right, back in this room, please go ahead.
Good afternoon. My name is Lily Beth. I'm a member of Unite Here Local 2. I work at the Olympic Club for 19 years as a front desk representative. I am here today because I feel healthcare is important to me because I have a son who is severely allergic to peanuts. And there are a couple of times where I had to call emergency services for an ambulance to transport my son just less than 5 miles from a home. I got the bill and it cost me about $3,000. Luckily, I only had to pay $50 because of my plan. Every dollar that I save on getting my son's EpiPen when it expires is a great help to me. And you know how the EpiPens are very expensive. Also, I would like to say that my coworkers and I sacrifice on getting increases with our wages and our pension when we negotiated our contract with our employer, just so we can put our money towards our healthcare costs. I have diabetes, thyroid, high blood pressure, cholesterol. So I take medication every day, and knowing that I have healthcare coverage through my plan, it helps me greatly. I strongly believe that everyone deserves affordable healthcare, and it should be a human right. Thank you.
Thank you. Do you have any virtual hands?
We have a virtual hand. Go ahead, Catherine Sullivan. Catherine, you'll have to unmute yourself.
Can you hear
now
me?
We can hear you.
Okay.
Yes, thank you.
Thank you. My name is Dr. Catherine Sullivan. I am a California licensed physical therapist who specializes in neurogeriatrics. But more importantly, I'm actually a public health researcher who does outcomes research. I was trained at the University of Southern California and also did a postdoc at the University of California in Los Angeles. The issue that is concerning me about managed care is that we're not really talking about strategies to make healthcare more accessible, which can easily be done by different strategies that mobilize all of the licensed professional workforce here in California. So we have a large number of professionals who are licensed and are qualified by Medicare, but we're not integrating the Medicare with the Medi-Cal system. And because of that, there is an incredible shortage and lack of care provision at the Medi-Cal level. So I really hear what everyone's saying, and it concerns me because I am an epidemiologist, and I'm in Riverside County now. We have 200,000 people who are of 2 million who should be getting what's called Medi-Medi, which is Medicare and Medi-Cal benefits. If they only get Medi-Cal benefits, they're not going to get the full scope of federally funded and state-funded healthcare options. So this is not something that I can obviously discuss in this phone call, but I do want someone from the committee to contact me because all of these individuals who are limited to Medi-Cal only
10
are
seconds.
not getting the benefit of being able to integrate the federal and the state systems. So thank you very much. And you have my contact information. And I also sent an email to the group.
Thank you very much. Next speaker here in this room, please go ahead.
Hi, my name is Fabiola Benavides. I working for the Hyatt Hotel Soma in San Francisco. I'm a member of Local 2 for 21 years. I'm here because I'm coming talking not only for my husband, but for my friends and co-workers. They are sick. I had my husband in dialysis 3 times a week, but my insurance doesn't cover all. I need to pay more money, more money, like $3,500, and plus I had to pay the ride too. So I think it's time for all people we are working. You have to do something for us because pay the rent in San Francisco is no easy, and we don't have enough money even for the food. We just only had a lot of depression, a lot of people get stressed, and this is get more sick especially for myself because I'm the one to take care of my husband. I had to do a lot of job by myself and still waiting for the bill. And we really need the insurance cover all, especially for the people we are working, because I saw my coworkers, they had cancer and sometimes doesn't cover too. So I'm not only here talking about myself, about my husband, but I saw my coworker in the hotel, some die already for cancer. The people still have cancer, but they need to start working. They cannot be rest. They cannot be staying home. Why? Because the insurance doesn't cover nothing. We need you stand up for us and helping us to the insurance cover ourselves too. Thank you.
Thank you. Virtual speaker next.
Moving to Terry Evans, go ahead. And Terry, you're unmuted on our end. You'll need to unmute on your end. All right, moving to podium. We'll come back around.
So back in this room, please go ahead.
Good afternoon, and my name is Mia. I work at the SFO as a snack bar attendant. I've been a member of United Here Local 2 for 15 years. I'm here today because everyone deserves access to affordable health care. For me, I have had a high blood pressure for more than 10 years, and if I didn't have affordable health care, I could not afford to pay for my rent. As the cost of living is rising in the Bay Area, medicine cost would be difficult for me to afford as well. I was involved in the SFO strike, which we fight for affordable health care. Thank you.
Thank you. Okay, still in this room, we invite the next person up to the podium.
Good afternoon. My name is Tony Evans. I'm a bartender at the Chase Center in San Francisco, home of the world champion Golden State Warriors, I must say. Healthcare is very important to me because the Medicare doesn't cut it at all. I had so many co-pays outside of my healthcare, I wouldn't be able to be here today. At the Chase Center, we get healthcare for 5 shifts a month, right? So that means every time I go through the door, it's $2,000 a month. Every time I go through the door, it costs them $400. If medical costs continues to rise, that means they're going to fight us and try to take that away, making more shifts for us to qualify. And any of us who's on Medicare, you know how that goes. I'll be 70 years old this year. I can't afford to stop working because the old machine ain't good as it used to be. and I'm always having some kind of issue that's outside the realm for Medicare. So that's why I'm asking this board, please govern yourselves accordingly. Thank you.
Thank you. Next up to the podium here, we welcome you.
Good afternoon. I'm Andrew Kiefer, and I'm a suffering Laker fan. But Andrew Kiefer, I'm with Blue Shield of California, and this is a surreal moment for me personally, since I've worked on the creation of this on behalf of my company for over 5 years. But before I get to that, I'm not going to talk about the why. All the previous speakers have declared exactly why we need to do this and why the time is right. But rather, I'd like to reserve my comments for just on behalf of my company, who stood at the podium and in the meetings before there was a podium and before there was an organization associated with this work to try to lift this up and get it off the ground, to say thank you for those who did get it off the ground. And in particular to Secretary Ghali, Dr. Ghali, your leadership, Elizabeth Fajal, the tireless amounts of conference calls. I did a conference call from a funeral as we were closing out the final details of this. Certainly our friends at the Purchasers Business Group on Health, and a whole host of others. And I hear Beth behind me. I've become best friends with Beth. That's long time prior to that. But the genius of this work and certainly the opportunity here is not only are we looking at costs, but we're looking at an opportunity to transform the healthcare system in a way that the piecemeal efforts in the past had never have. And the leadership from our governor, from Dr. Wood, and certainly Dr. Pan in the legislature, to get this across the line is a huge achievement. And I think goes into the long list of achievements that this administration's had to really bring healthcare and the improvement of the system forward in a way that I think no other governor has. Really looking forward to working with you all and really lifting up the opportunity here on behalf of everybody who spoke before me and all of our friends and family who deserve a better healthcare system. So thank you.
Moving into the virtual room, Terry Evans, go ahead.
Hello, my name is Terry Evans. I work for the Watts Health Center Corporation. I'm with Local 721 SEIU. Just a few comments just about the healthcare in my department and the whole company. We'll have a lot of coworkers that really can't afford the healthcare. They will go on Medi-Cal instead of taking the insurance from the job. With the patients, we have patients that come in and pay from $50 to $100 a visit. That's a big impact on a lot of the people that work there and the patients. So hopefully they can do something about it so everybody can get the right affordable health care. Thank you.
Thank you. All right, we invite you to the podium in the room here.
Hi, everybody. Ben Johnson from the California Hospital Association. Just want to be here to congratulate you all on the amazing progress that's been made over the last several months and on the inaugural meeting of this board. California Hospital Association was pleased to be able to engage in the legislation as it was being implemented. And I, for one, hear the amazing struggles that folks have been sharing today. And so we look forward to working with you as you chart a path forward to create really a high value healthcare system in California that really works for all of us. Thank you.
Okay, and we invite what may be our last speaker up to the podium here in the room.
Hello, I'm Alejandro Rayburn. I'm staff of Unite Here Local 49. I'm also on the trust fund, the Taft-Hartley Fund for the local. And every time we meet, right, we see the cost of healthcare. For our members in Sacramento, healthcare costs have gone up since 2006 about 520%. That's way outpacing inflation. If costs had only gone up at the rate of inflation, housekeepers in our union could have been bargaining for about $100,000 more in wages over that time period. So You all, the AHCA have the Office of Healthcare Affordability have the opportunity to set real limits, and so we call on you to set real limits. And right between now and the time that the enforcement deadline, the enforcement starts, right, that's another about $50,000 that housekeepers are projected to lose to healthcare rate increases. Thank you.
Thank you very much. That concludes our item 2, and we appreciate all the public comment. I'm now pleased to turn it over to HCI Senior Attorney Jean-Paul Buchanan, who will give an overview of the Bagley-Keene Open Meeting Act and conflict of interest provisions.
Good afternoon. My name is Jean-Paul Buchanan. I'm an attorney here with the department, and today we'll be discussing open meetings, also Bagley-Keene, conflicts, and a reminder on Form 700. So the Open Meetings Act, also known as Bagley-Keene, has the primary purpose of allowing the public to participate as fully as possible in a state's body's decision-making process. This is applicable to this board because this board was created by statute. It's also applicable to the advisory committee that's going to be formed. And so Bagley-Keene will apply to both of those. Bagley-Keene requires that the public have a chance to attend and participate in meetings of public bodies. And a meeting is defined as a quorum of a state body, which is meeting in the same place at the same time to discuss or deliberate something within its jurisdiction. Slide 4, please. The physical location and presence requirements have been suspended because of COVID, but those will be going away at the end of June. That means they'll be more likely to have in-person meetings, and at in-person meetings, the public shall have the ability to review materials, either online or provided at the meeting itself, and have a chance to participate in the discussion. Next, please. Other meetings that need to be, we need to be concerned about is serial communications. Serial communication is where somebody talks to a quorum of the body, a majority of the body, and presents information and informs the people they're meeting with the positions which are being taken by other members of the board. The reason we prohibit serial communications is because we want members of the board to deliberate when the public have had a chance to present their version and their facts, and before any vote is made or any decision is made. Next, please. There are exceptions to the meeting requirement, and those are public meetings that aren't solicited by members of the board. Social gatherings where a majority of the board does attend, but it's a purely social event and they do not talk about any issues that come before the board. The final thing is conferences. Conferences are on a general interest, which are open to the public and where information is presented of a general nature to both the members and the public. Next slide, please. Board members attending subcommittee meetings, and that would be the advisory council, would be included in this. A concern comes about when a quorum of the board attends a meeting at the advisory council and starts discussing issues that would come before the board itself. You may attend, but you are recommended to attend as an observer unless directed to do otherwise by this board. Next, please. Notice and agenda. The public must be provided notice of the meeting and be provided an agenda of what will occur at the meeting. The agenda must be specific in that it provides the public with enough information for it to make a determination on what business will be conducted by the board at that meeting. Next, please. Again, public attendance and participation. The state is committed and the Constitution requires that we operate with transparency so the public knows what its government is doing. For that reason, the public have a right to participate on each agenda item before the board can make a vote, take a vote, or on an agenda item where the board discusses or makes recommendations on an agenda item. Additionally, if the board has a member appearing remotely, the board must provide the public with as much communication, i.e. the means of communication that the board member gets. Next, please. Closed sessions. The board is allowed to have closed sessions, and those are either laid out in the Open Meetings Act or in the enacting statute for this board. Next, please. Meeting documents that are distributed board members prior to the meeting must be made available to members of the public at the same time. Next, please. Voting. We have a non-voting member of the board who does not count towards the quorum. Any business conducted by the board needs to be conducted by a majority of the quorum. And if somebody abstains, they will be counted towards the quorum, but they will not be counted towards the vote majority. Next slide, please. If a person abstains, this begins to complicate voting because there is a small board here. And so anybody who abstains will reduce the number of votes available, and we still need a quorum, a majority of the quorum. So if people abstain, then we have to watch that to make sure that we're moving forward correctly and we're not having a small minority of the board making decisions. Next, penalties for non-compliance. The most significant penalty as far as the board is concerned is that if we violate Bagley-Keene, that we void any actions taken in that meeting. Additionally, if an interested party wanted to bring an action, interested party, it can be a member of the public, district attorney, or the attorney general. They can bring about a civil action, and again, the consequences of this are that the board's actions will be voided, but also that the potential for costs and attorney fees could be levied against the board. Finally, criminal action. It is a misdemeanor for any of the board members to violate the Open Meetings / Bagley-Keene Act. I don't anticipate that will happen, but it's always nice to have a reminder. Next, please. Sure. If you have a question, please let me know.
Thank you. And again, appreciate the presentation. As you made note, Mr. Molds is a non-voting member. So when it comes to Bagley-Keene, and I think the intent is not to try to discuss things outside of our official meetings, but if there were three of us and he was the fourth present, does that trigger the issues that you talk about? Because he's not a non-voting member of the board. So I just want to clarify that if we're in a place and there's three of us there and Mr. Molds, does that trigger Bagley Keene or not?
I will channel somebody who's no longer here, but many of us will know, Carrie Rudman, who was the head of the ethics for the state Senate. And when I would ask him a question, his response would be, the fact you're asking me that question means you shouldn't do it. And so really, there's a number, and we'll get onto that as we look at the conflict of interest, which we're about to do. But we're interested in not just living by the letter of the law, but Bagley Keene is one of those where the Constitution says if there's any question, it's to be interpreted most generously towards the public. And so what my recommendation is that there will be regular meetings. If it's something that you feel should be discussed amongst board members, that you request to be put on the agenda and discussed in public for the benefit of the public.
No, I appreciate that, and certainly I think that's the general intent. But since you are our counsel, I just wanted to have some clarity, because if something came up and it's, I shouldn't assume anything, but incidentally we happen to be in the same place and someone brings up something, does that trigger, what exactly does that trigger? So I think that is the desire for some clarity there, not because there's an intent to try to hold a meeting with three of us plus Mr. Molds to have a actual, predetermined discussion about something that's coming up before the board. And then in terms of abstentions, and just to clarify, and I don't know there are particular parliamentary rules that apply to this particular body or not, or to state boards. So as you mentioned, when people voluntarily abstain, it's counted toward the quorum, so that allows the vote to occur. But especially since our quorum is essentially 4 votes, right? Yes. And I understand Mr. Molds would not count toward the quorum because he's a non-voting, right? No. So theoretically, I guess, well, if there's only 3 people could actually, because that would be the majority of the 4, could actually make a decision.
Yes.
Correct? Okay, thank you.
And to answer the question on what rules apply, Robert's rules typically applies unless another form of parliamentary procedure is outlined. You can always write your own rules of parliamentary procedure, but it does take a little while, and I would recommend that you don't.
Well, in the legislature we use Masons, so I just wanted some clarity, that's all.
I do believe Masons is used in the legislature, but it's not used here. Okay, so conflict of interest. Any other questions before I move on to conflicts? Conflict of interest, but it comes in 2 forms, statutory and common law. Statutory is those rules that are created by the legislature, have been created by an initiative and placed on us, such as the Political Reform Act. Whereas common law rules are rules which are made by judges. So on financial conflicts, this is where the PRA has most to say, and that it requires that the board members perform their duties in an impartial manner, free of bias, and free of bias towards their own financial interests or the financial interests of people who've supported them, be that employers or family members. And that under the common law, there's a similar thing. There's a prohibition on self-dealing. So one of those things is where people should not be voting on something that would have a direct impact on them. So that's the financial impact issues. Talking about financial conflicts, Form 700, I believe most of the folks here are well aware of Form 700 and have completed them. And that is a public document which will allow members of the public to look at what your financial interests are and to determine whether you're living up to that prohibition or not. Also, there's incompatible activities. Incompatible activities is a broad concept which is being put into statute and also has a common law component. And so this is somebody shall not engage in something that is clearly inconsistent or incompatible with their duties as a state officer. So the question then becomes, well, really, what does that mean? Because that is a broad statement. And what that means is that the public have to assume that any decision you make, you will recuse yourself of anything where there's a potential incompatible interest. If you believe you may have something that's incompatible, then you should obtain advice on whether it is incompatible. And if it is, you should recuse yourself from that vote. You should recuse yourself from providing any comment or trying to influence the board on that vote. So if anybody has any questions, I'd be happy to answer them. Otherwise, yep.
So I guess the follow-up question is that if who do we consult about potential conflicts if we have questions? Is it your counsel, so we should consult you, or who should we turn to if there's any, again, question in the mind? I realize you did say if you have a question in the mind, but I think, I mean, there are circumstances where someone may say that, oh, well, I just want to be sure I'm doing this correctly, and so who on staff is the person to turn to if they want to explain the situation, to be sure that they are appropriately following the statute and not having conflict?
I would recommend you contact the staff of the board if they feel that you're. I am with the legal office. The board has its own attorneys.
Okay.
I'm here not to influence, but just to guide. And
So
Yeah, if there's a legal question, you're welcome to start with Megan Brubaker, and then we'll
Okay.
direct it as needed. Thank
All
you,
right.
Doctor.
Thank you.
there are no more questions. Thank you.
Terrific. With that, we are going to take a 10-minute break. Please return by 3:20. Thank you. All right. Back to work, everyone.
Testing, Meg.
This is the problem with taking a break. It's the wonderful thing about taking a break is people are happy to see each other. Okay. Let's see. Yes, all board members are back in the room. And Dr. Hernandez, are you there as well?
Yes, I am.
Wonderful. Thank you. It's joyfully rowdy in the room, but now things are
I
quieting
can see
down.
that. I can see that and I
Okay.
can hear that.
Well, we'll look forward to having you here next time.
I
Okay,
miss the
we're on to
rowdiness.
we are on to item 4, which is election of the chair. So under the statute, the board must elect a chair. And so I just now open it up and invite any nominations for board chair. Yes, Dr. Carlisle.
Yes, I am honored to nominate Health and Human Services Secretary Dr. Mark Galley for the position of chair.
I second that motion.
Okay. Dr. Galley, would you like to say anything?
I worry about how quickly everyone seconded that motion. I mean, yeah, a lot of enthusiasm for that. I will say it would be a tremendous honor to be chair of this board. I think the role of chair, not just to work with Elizabeth and your very capable team, but to garner really the expertise of the board members make sure we're paying attention to the North Star that is the people that just left this room, many of them that talked about their personal struggles. And I think, Elizabeth Mitchell, you asked, what is this about? And I think we heard the story pretty clearly during public comment of what this is about. So it would be a terrific honor of mine to help garner the voting and non-voting members' expertise in guiding this work to ensure that working with Director Landsberg, Rachel, that we craft agendas that really reflect the mission and vision that, as I said in my opening remarks, is really we're standing on the shoulders of lots of people who for years and frankly decades dreamt of this day, and to do right by that mission would be a true honor. So if it's the will of the board, I'd accept it with a great deal of gratitude.
Thank you. Are there others who'd like to? Yes, Dr. Pan.
I certainly also would be appreciate and would welcome Secretary Ghali to be chair of the board, but as also someone who helped author the statute, there's a reason why we are having an election and we didn't designate the secretary as the chair in the statute because this because of the we want to be sure this board was independent. So while certainly I know of Dr. Ghali's work, having partnered with him on this legislation, his expertise, et cetera, I think is certainly, I think as our founding chair, certainly very supportive and will be voting for him. I also make note that this should not be a precedent for this board, that the secretary automatically becomes the chair. So it was very intentional that way in the statute that we elect a chair, not actually designate a member of administration as the chair. So I do feel like I just need to clarify. I have certainly very happy to have Dr. Ghali, and certainly his record speaks for itself, not only as secretary, but also his own his own record as in policy and leadership. So it certainly makes a lot of sense. But I also just need to make the point that that should not be an automatic, the secretary becomes the chair. Thank you.
Thank you. Are there other board comments before we move to public comment on this item? Public comment on election of a chair.
Beth Capel on behalf of Health Access California. We would strongly support Secretary Ghali as the chair. We have had the experience of him being elected as repeatedly, I think, as the chair of the Covered California Board, which was in part the model for this. And he has done a very good job there, despite having to manage a once in a century pandemic at the same time. So, which has necessitated relying on his then vice chair and now with you, Sandra Hernandez. So we would look forward to his leadership again. Thank you.
And do we have any virtual public comment?
No virtual public comment at this time. For the virtual folks, you're reminded to raise your hand if you'd like to make a comment.
We'll give it one more minute and then we'll move to a roll call if there is no public comment from the folks participating virtually.
Just confirming no virtual hands.
Okay,
All
we'll
right.
do our first roll call vote of this board.
Secretary Mark Ghali. Apology.
Can I abstain from voting for myself?
You can.
Yeah, what a bad precedent. I will vote for myself.
David Carlisle. Sandra Hernandez.
Aye.
Richard Kroenig. Ian Lewis.
Aye.
Elizabeth Mitchell. Richard Pan.
Aye.
Secretary Mark Ghali is now the chair of the California's Healthcare Affordability Board. Congratulations. For the purpose of efficiency, I will continue to chair this meeting and we'll have Dr. Ghali chair our next meeting. And with that, we are pleased to move on to item 5, healthcare spending targets.
So for this agenda item, we'll be discussing healthcare spending targets. I'm pleased to introduce Michael Bailett, the technical expert OCA has engaged on planning for our spending target program. Just to tell you a little bit about Michael's background, he founded Bailett Health in 1997 and has since worked with a wide array of government agencies and employer purchasing coalitions in over 30 states. He is a national expert on spending target programs and leads Bailett Health's work for the Peterson Milbank program for sustainable healthcare costs. This collaborative advances state-based efforts to make healthcare more affordable for residents, employers, and states through providing technical assistance to 6 states as they implement their spending target programs. I will now turn it over to Michael to provide an overview of spending targets, including their intended purpose, examples of measurement and reporting, and lessons from other states.
Thank you, Vishal. Good afternoon, everyone. I'm really excited to be here with you and look forward to working with you over the coming months. I'm going to provide you with an introduction to spending targets. I would like to invite you to interrupt me at any point in time or with any questions that you might have. This isn't going to be a very deep dive PhD level. This is really just going to be an introduction to help orient you. Okay, so, whoops, I went too far. So what is a spending target? Why pursue one? So in its essence, it is a per capita change over time target. So it's not about measuring what is spending or comparing spending over here to over here, or organization A, organization B. It's all about measuring change in time. States have adopted spending targets to slow healthcare spending growth, both because of concern about spending growing faster than economic growth, but also because of concern about it growing faster than income or wage growth. Here are some of the cited reasons that states have identified for why they pursued it. And it's different. In Massachusetts, it was because healthcare spending was eating up the state budget, and spending and everything else was going down or flat while healthcare was going up. But some other states identified it for different reasons about household burden or healthcare spending relative to state economic growth. States have set their spending targets using a public body like this one. They differ a little bit in that some of them are what I'll term protected bodies, where those that are interested in the outcome are not at the table. In other cases, they are broad-based stakeholder groups where everyone's at the table. So obviously, this body is in the former. When states have set their spending targets, they typically have tied the target to one or more economic indicators. Now, the statute that's created this initiative envisions potentially considering non-economic indicators as well, as I think Vishal described earlier. But in the states that have preceded you, it's been one or more economic indicators. Okay, and we will go deeply into that topic at a much later meeting. So as I said, your enabling statute talks about considering population-based measures. Ultimately, states have picked targets between 2.8 and 3.8% through 2022. And generally, those targets have been about 2 percentage points less than historical spend in the state. We're not going to be talking about target setting till the fall, so that's a ways off. But when we do, we will share with you the details of how other states have approached it, what have been the economic indicators, what was their historic spending growth, what did they settle on, what's California's spending growth look like, just to help you be informed in that conversation. All right, so I say through 2022, all of those targets that were set in that range were set pre-pandemic. So the pandemic has brought on conversation about inflation because all those other states set their targets when inflation was low. And it had been low for a really long time in the United States. We had almost forgotten what inflation was. So all of those states set their targets with the assumption that inflation was going to grow at the Fed's target of 2%. Okay, and clearly it has been above 2% since late 2021. So we will talk about inflation in the future and what impact it may or may not have on your planning. By the time you're setting a target that's going to be enforceable, or even setting a target just for reporting purposes, we don't know what inflation is going to look like in the United States. It will probably look different than it is at this very moment in time. But we'll share with you information about what do we know about the relationship between inflation and healthcare spending, and how have other states wrestled with the question of do we adjust or not. And I will tell you that states have differed in the approaches that they've taken on how to deal with inflation. Okay, so in my mind, this is the most important slide that I'm going to share with you today, because it puts the spending target in context. The spending target in and of itself will not be sufficient to slow healthcare spending in California. At least that's my prediction. There need to be complementary actions. And so this is the logic model that we're using with the 6 states in the Peterson-Milbank program that all have spending targets. And I want to walk you through it. This is much broader than what we're going to be working on together this year, but I think it's important to put the target in context of a larger effort to improve affordability. So I'm going to start with that yellow scale in the top right. Given that a state establishes a spending target, its first step is simply to measure performance against the spending target. But that's going to give you very high-level insight into what's happening. It will describe spending by insurance market, maybe by geography, by insurer, maybe for large provider organizations. It won't explain to you really in any nuance why spending is growing. There might be some service category level, but we won't know why. So states complement, and I'm going to go into this in some detail in the following slides, the spending target measurement with analysis of spending at a much more detailed level. And that involves looking at claim level data and hopefully leveraging your HPD in the near future. So that means getting into, well, so we know, for example, our pharmacy spending is growing. Well, where's it growing? Is it in brand drugs or generic drugs? Is it in medical pharmacy, the infusion drugs, or is it in retail pharmacy? And let's say it's in brand drugs. Well, which drug category and which drugs and which manufacturers? All of that you're not going to get out of the spending target analysis, but you can get out of analysis of claim level data. And so the other states have created a complementary work path to try to understand spending sort of under the hood proverbially. Step 3 is public reporting, both of target performance, but also of this complementary cost driver analysis, and making all of that public. And the other states that have their targets, they are all in reporting season right now. So between March and May, they're all reporting and making things public, which is a big deal in the other states. And frankly, it's a big deal for those being reported upon. And so that reporting, that transparency draws a lot of attention to this work, and appropriately. And were this logic model to stop there, there would probably be some impact. I don't want to say that it's not enough, but probably not as much impact as is needed to have long-term sustainability. And I'm going to emphasize the long term, because I think in the short term, out of transparency, you can get a significant amount of impact. But over the long term, I'm not sure it's enough. So these last 2 steps are identifying opportunities to slow spending growth. So through that cost driver analysis, say, oh, we see that over here, we have a principal cost driver, and we want to focus there. And then identifying strategies, and then ultimately implementing them. So I think that's the full logic model, and you can see there's an arrow in that circle because it's a circular or iterative ongoing activity. Any questions or comments on this?
Just one maybe small, maybe larger question, but so the APCD, as I understand it, is still being built. So where does the data come from?
Well, from what I understand, it's getting pretty close.
We will start public reporting this summer.
Okay, so
Yes.
it will be done, that will be a source in time to start this process.
Yes, we won't have everything available immediately, but we will start having data, and we've started to look at prototypes, and it's very exciting.
Great, helpful, thank you.
Sorry, related, will you be using the newly available CAA data, the hospital reporting, the health plan reporting, and soon to be PBM reporting? That's federally required. The newly available data on
Yeah,
prices and costs.
is a question about the hospital rates that are published?
Hospital rates.
Okay.
Now we're also getting negotiated rates from plans and soon to be PBMs and consultants as well.
Yeah, that's a good question. We could follow up on that with our HPD team.
Great, thank you.
I mean, in terms of total healthcare expenditure data, we'll be getting that from payers, but with some of the analysis, those could be useful data sources.
So we just came out of COVID. You mentioned the fact that a lot of targets established before COVID. You have events like COVID, you have technology transformations, even baseline things like aging population. I mean, part of the reason that's in the statute is because, for example, for long-term care, when we talk to Department of Finance, Department of Aging at the state, we figured out if we tried to deliver the same level of service like from year to year, essentially because of the aging population alone. All right. Now, obviously, we can say, well, maybe we can deliver better, or more effectively, or whatever. But it would have those in-home supports and services basically would have to increase 5% per year, which is, of course, faster than our overall growth. This is before inflation, by the way. So in real dollars. So as we look at this, I mean, we have a lot. Everyone's going to be looking at claims data and so forth. How do you? I mean, is that part of the analyze? How's that part of the equation factored in? So you have changes in utilization. Some of it, of course, could be behaviors within, but also some of it could be these large things. It's an aging population is going to use more healthcare services because they generally have more illnesses, right? An outbreak, a COVID, or something even smaller will drive more. So how do we factor that into this?
That's your work.
There we go. Okay, so hopefully we'll all think about that.
Yeah.
This is a question maybe about timing, but one of the public comments that stood out for me was somebody who spoke from the Monterey Peninsula who, with insurance, out of co-insurance, ended up tens of thousands of dollars in debt for hospital services there. And at the same time, just a few miles down the road is one of our rural hospitals, which is on the brink of insolvency. So it strikes me that if we set a target of 2.8% statewide or what have you, some are going to have to come in a lot lower than that, and some are going to have to be given latitude to go a lot above that because of the inequities that are baked into our system as it stands today. So, I know that the defining sectors and sectoral targets is staged later in our timeline, but it also seems to me that we need some discussion of that and some sense of where we're going on those questions in order to make sense of what a statewide target is.
Right. So this is an issue in every state, that there's huge variation in healthcare spending and in prices. And this issue of variation especially in prices is like the third rail of health policy, because nobody wants to try to figure it out. I mean, I know that in Massachusetts, in a half dozen years, they had 2 state commissions on this topic, and neither of them did anything. So this is something that you all need to talk about. The reason nobody does anything is it's easy to say those people with low prices should come up, but politically bringing the prices down for those with high prices, no one's been able to do that. So, but you're right. If you apply a flat target everywhere, you not only are freezing in place the differences, but actually over time they're going to actually get bigger. Yeah. And that's a reality. And that's a very hard policy challenge. Rick?
My question is actually probably more for Don and Elizabeth, although maybe a little for you, and maybe it's actually mostly rhetorical and doesn't even need to be answered. But when I look at this logic model, most of what's here is, I think, pretty similar to what Don does at CalPERS and many of Elizabeth's, jumbo employers do themselves. The public reporting a little bit different. Neither Don nor the jumbo employers do much by way of public reporting. And the implement strategies, to the extent that there is at the very back end potentially a big hammer here that neither Don nor the jumbo employers have, maybe there's a strategy available here that's not available to employers today. But a lot of this is pretty similar to what gets done. And so I think the question that I'm mulling around, and that probably is a challenge as we move forward, is what about this is sufficiently different from what large employers are doing now? Maybe part of the answer is scale. If we're doing this at a statewide scale, there are more resources. Part of the answer might be public reporting. Maybe part of the answer is the potential enforcement hammer. Maybe you've got better answers now, or Don or Elizabeth, you've got better answers now. Something to kind of.
I think it's all three of those things.
Mind,
Certainly, it being so public and transparent makes it a lot different. But the other two factors that you mentioned, also matter.
We have the hammer. We just don't use it. And it's going to present the same challenge for this group. I don't disagree with anything you just said.
Mm-hmm.
I don't either. I would also just point out, though, that claims data doesn't measure affordability. So
no.
I just want to make sure we stay oriented to affordability as experienced by patients and purchasers.
Right.
So I understand all of these data sources. I just want to make sure we don't stick there with just production costs. We're talking about the cost to the.
Right. Some of the data that Vishal shared about the percentage of the population that's deferring or not seeking care, that's a person-centered view of affordability. Right. And yeah, the claims help you understand what's happening in terms of utilization and spending, but it definitely is not about affordability.
I'll ask the question now. I was going to wait a little bit, but one thing that strikes me is not only does it not measure affordability, but the value proposition that I think is really important to this group is, through the presentation, be curious how we draw that out a bit as well. One of the statements is we're not trying to just come up with the lowest cost healthcare system. We're trying to come up with something that meaningfully moves the equity principles that this state, not just this board, but this state has really sort of reflected, and understanding in your experience and advice to the board as we move forward, how we draw that value proposition out of this, because I think all of us, including the folks who came up for public comment, I think really were not just focused on how hard it was to pay the bill, but how hard it was to access the care that they need in the timely way that they needed it. So trying to understand that piece, I think, will be important, and curious how that comes out in the rest of this conversation.
Yeah, I'm going to talk a little bit about equity later on. In terms of, there are lots of ways of thinking about value. One is valuing different services. So the statute a little bit says something on this because it values primary care spend. And there are at least a couple of other spending target states that have said, we want to bring up primary care spend while slowing overall spending growth. So what does that mean? If primary care is growing faster, that means everybody else is growing even slower than what the target is. So that's a value statement of one type.
I think you actually just answered my question in part, but what are some of the differences or variations across the states that have spending targets already in terms of how they've been able to get there? They're not just moving monolithically necessarily. What have you seen across?
Moving, meaning to achieve it?
Yes.
So Massachusetts started with legislation in 2012. There was no action in any other state. There was no target established again until 2019. And then COVID came in 2020. So I would say that the efforts in the other states are relatively immature. I mean, certainly they've been doing it for a few years now, but yeah, I think there are some but limited lessons to learn.
Is there something to
Right, so
learn from Massachusetts?
Yeah, I'm gonna talk about Massachusetts later on. Things to learn, you know, for the good and for the not as good both. But you know, that's the danger of being first. Okay, so I'm isolating here the two different types of spending analyses. The spending target data analysis, so that's on the left side. That's what we're going to be focused on here. And it uses in other states payer-reported data that is provided in aggregate to the state. Okay, that's in contrast to the cost driver analysis using the HPD in the future, which is claim level. This is not claim level. So payers submit big categories of spending that they have analyzed and provide to the state. It does not represent all of the spending in the state. It represents most of, but nearly all of it. So this is an advantage that it's going to have over all payer claims databases like the HPD. By asking the payers to provide it, you can obtain self-insured employer spending, which is over 50% of the commercial market, which will not all be in the HPD. You can also obtain non-claims-based spending to the extent that it's not in the HPD, and you can obtain pharmacy rebate information, which is a significant adjuster to pharmacy spending in all markets. Okay, that's in contrast to the drill down analyses that are done with all payer claims databases in other states, and almost all the other spending target states have all payer claims databases. Okay, those databases are limited because they don't have the self-insured market, they don't have pharmacy rebates, they don't have non-claims based payments, but they still have a lot of information that provides insight. So I'm going to give you, yeah, go ahead.
Just a question on the use of APCDs elsewhere. California, I think, is a pretty uniquely HMO-heavy state, and I know that, or I understand that some of the risk adjustment methodologies weren't designed with capitated data streams in mind. Could you shed some light in like how much you think we can rely on our HPD given the unique HMO?
I'm not expert enough on it to know. Certainly that creates a different issue for California than for other states, but I can't opine on it.
Yeah, the only thing I will say is that we are, in addition to claims data, we're getting encounter data, and we are looking at how to capture capitation and non-claims data, but it won't be, it certainly presents challenges.
Rick?
Michael, you may want to defer this to a later meeting, but on the left-hand side, the spending target data, it was my understanding, maybe incorrectly, I'm sure you know more than I, that in Massachusetts, those aggregate data are primarily focused on Massachusetts residents who are in HMOs, in capitated environments, that they kind of the PPO side, there may be some reporting, but at least when they get to the sort of payer provider group.
Yeah, so Massachusetts is the only state that does that.
I was going to ask, are other states like that?
No.
Okay, thank you.
No, so I referenced both the good and the bad lessons to learn from Massachusetts. Massachusetts methodology is in statute. So, you know, what was written in the 2012 legislative session is still stuck in their statute. And that's unfortunate because they've had difficulty evolving their program in some ways because of that. All right, so a little bit on what states have been doing. Looks like my battery's run out. Can you guys advance the slides for me? Great. Okay, so in states that have done something with their all-payer claims databases, they've been using them recently in ways that states had never used them before. I think to some extent, a lot of states had all-payer claims databases and didn't know what to do with them. But spending targets have created a use case. And so now they have created standard analytic reports that are dynamic. So they use tools like Power BI and Tableau and these commercial products and lay out spending trends over 5 or more years, and that allow for all sorts of sophisticated analysis. So I want to share with you, next slide please, just some, first an analytic construct and then examples of what some other states have done. So the analyses focus on answering 3 questions: where is spending problematic, what's causing the problem, and then looks at not who's accountable, but how can we assess accountability at these different levels. So in terms of, yeah, you can go on. So where spending is, should work again? Okay, great, thanks. So this is looking at where is spending high and where is spending growing quickly. And those are not always the same. There's some areas where spending might be very high, but it's flat. And other areas where it's low, but growing quickly. So this is one way to understand what's going on that proverbially under the hood, to get some insight. Because if you want to work your way around my logic model to get to solutions, you have to understand where's the problem first. So understanding where is certainly a first question. Also, where can be understood in terms of geographic variability, and in a state the size of California, that's a relevant measure where it's not for geographically small states. Can also be looked at in terms of patient population characteristics and provider concentration within the market. You can also identify where spending might be problematic by making comparisons to external benchmarks. So some of them are public, and I've listed a few of them here on the slide. But increasingly, the healthcare spending target states are able to benchmark against one another. So I, for example, am doing a call on Friday with the lead guy in Massachusetts, and we now have for 2021 detailed data on what was going on in Massachusetts, Rhode Island, Connecticut. They're all right next to each other. And so we're going to be comparing the trend information and say, what can we learn about the differences here and the similarities? In terms of the second question, we want to look at drivers of spending and spending growth. And so these standard analyses always start by breaking apart price and volume. I want to clarify that often when we say price, what we really mean is payment per service unit, not price. And why is that? Because the third variable here, intensity or service mix, is very hard to tease out analytically using claim data, largely because provider organizations are financially rewarded for the completeness of coding. And so what sometimes can appear to be increased service intensity or sicker population is not that. So I've got intensity there, although intensity or service mix is hard to tease out. The other characteristics for analysis are population characteristics. That gets in part at an equity lens and understanding how does spending vary by population. And then last, and this is more an ad hoc analysis than it is a standardized report, understanding the role of provider supply. Okay, so that was a little digression into work that we will not be talking about, but I think is important to understand as part of the broader logic of how do we make a spending target work. So let me talk now a little bit about spending targets and health equity. Oh, I'm sorry.
In your assessment, have any of these other states been effective at actually lowering costs? And one of my questions is, all of those analyses are super interesting, but how much will we be able to use them in terms of actually doing something about affordability? So it's like a process measure versus an outcome measure. Do they lend themselves to actually improving affordability?
So I think they do, but they're politically hard to do. Okay, but that's you actually asked two questions, right? So to your first question was essentially, does any of this matter? So I'm going to share some data later on from Massachusetts that I think provides evidence that it's had impact. From the newer states, I can tell you that I hear within the states that the insurers and providers, when they're negotiating, are negotiating with the spending target at the center of the table. And I think that that's one of the most powerful aspects of having a spending target, especially in the commercial market, because there's no, one of you said this during the opening comments, there's no constraint in that market the way there is in Medicare and Medicaid. And so when I hear large provider organizations saying that the dominant payer in the state is saying, okay, we're going to start negotiating starting with the spending target, then that tells me that the policy is having some influence.
Just for clarity, I'm asking so that we can be effective. Not that I think the work's not important.
Of course.
But I want to learn from what has been most.
We should all be skeptical about any policy initiative, right? Because we've all been working at this for a long time, and healthcare spending has been a problem for a long time. So I think skepticism is totally appropriate. Yeah, and I'm definitely not here to sell any snake oil. I just want to note that.
So my question is, what do the other states do? So they rely primarily or exclusively on their APCD to set these targets.
No, the APCDs provide additional analysis to understand what's going on in spending. Okay. But the setting of the targets, that's done by considering information that's not in an APCD. So that's considering how much has our spending been growing? How much are wages growing? How much is our economy growing?
Maybe I asked the question incorrectly. So in determining where we are, so the APCD plays a central role, but it's incomplete. How do we fill in information about the self-insured population, for example, or specifically? Is it by proxy? Is it through other queries? And if so, do we have that capability?
Yeah, that's a good question. So I have only one reference point, but Brown University did analysis of healthcare spending in Rhode Island's APCD before the Gobet decision led to all the self-insured claims leaving their APCD. And what they found was that spending patterns between the fully insured and the self-insured were similar.
That's what I was saying. Yeah, so you just assume that.
So I think it's a fair proxy.
But Don, if I and Michael, if I can, to make sure I understand what you said, and my understanding, Michael, is that the APCD is used to work on the cost driver analyses, but not on the target setting. The target setting data comes, in Massachusetts at least, and I don't know in the other states, from asking the payers, how much money did you pay? And in the aggregate.
Exactly.
In Massachusetts, it's, I think, how much money did you pay for people who are in HMOs? I gather in other states, it's how much money did you pay
for everybody?
For everybody. And so it's those data that are used to try to set the target and monitor performance relative to the target.
Right. Yeah. And just to clarify, Massachusetts does ask for spending in non-HMO products. They just don't measure and report on provider entity performance for non-HMO. Okay. And it's only Massachusetts.
If I might, you mentioned the call you have on Friday with the New England states. How far off do you think we are from being able to compare their benchmark, put our stats on par with their benchmarking?
Well, so our goal is to establish by the end of the year, or for a state to establish a set of regulations for baseline submission. Okay, so that baseline submission will be your first information to allow that. My guess is that the data won't come in perfectly on that first baseline submission, but you'll have it after that. Right, so a little bit on equity. Inequities appear everywhere, including in healthcare utilization and healthcare spending, and in the burdens that individuals experience. That's across a broad range of demographic dimensions. We are going to try to infuse equity into our conversation. So throughout the target development process, we'll ask, what's the equity implication of this decision? And I will say that the process that we're planning for you over the course of the year is to move sequentially through a series of what we call design decisions. And we'll take them one by one, and when you add them all up, you'll have a healthcare spending target methodology and an actual target. But we're going to try to encourage consideration of the equity implications of those decisions as we go along. Just one example here of equity when you look at healthcare spending. So this is percentage of healthcare spending relative to the distribution of the population. And you can see here, disproportionately, a lot more money goes to spending for the white population than to the comparator populations, as in relationship to percentage of the population. And specifically, you can see it most dramatically here for the Latino Latinx population. And Asian Pacific Islander. Yeah, 2 to 1, right? 2 to 1. Okay, so now I want to explain total healthcare expenditures and how they are measured in other states. We're going to go into much more detail in future meetings, but just to familiarize you. So this is the #1 acronym for you to learn from this meeting, THCE, okay? That's total spending all in. So it has largely 2 component pieces. One, something we call total medical expense, and then health plan administrative costs and profits, okay? So total medical expense, another acronym, TME, that and health plan admin costs and profits, together that's total healthcare expenditures. Within total medical expenditures, we have payments for claims, for reimbursement. We have non-claims-based payments. So those might be payments for services like capitation, but that could also be an infrastructure payment that's made for primary care practices to become a medical home. It could be any form of payment that's not reimbursement for a claim. And then we're also including cost-sharing obligations of members. And as you could hear from the testimony today, there's a lot of that right now that did not used to exist in the commercial marketplace, but the amounts are enormous now. So we're going to measure cost-sharing obligations because we can't actually capture whether the cost-sharing obligations were met. We don't know whether somebody paid their deductible or paid half their deductible. Okay, so TME plus health plan, and this is private health plan in other states. So it's not the cost of administering Medicare fee-for-service or Medi-Cal, but it's private insurance. So this would be Medi-Cal health plans, commercial health plans, Medicare Advantage plans, their admin and their profits. That together represents total health care expenditures. One last note, I'm talking about insurers here. There are some other forms of payers that represent smaller percentages of spending in the state. We will talk about those in future meetings and whether they should be included or not.
I'm sure you and everybody in this room has had more conversations than you'd like to be part of about defining the boundaries of the healthcare system. And, should we be including expenditures on various social determinants of health that really are part of health? The one that I wonder about excluding from here is public health expenditures. And I wonder if we do ourselves a disservice by not thinking about public health expenditures as part of health expenditures and as part of what, we want to spend more on public health, not less. But if it's kind of not part of this, I think we are in danger of losing it. And I wonder whether other states have dealt with that at all.
Other states have not included it, but that doesn't mean you can or shouldn't talk about
it. I fully agree, especially, even before COVID, but certainly after our experience with COVID, because public health services do impact demand, et cetera. And so when they're underfunded, then basically that cost gets shifted over in the outcomes to what shows up on these boxes. And then I think the other area is, long-term care. We're not directly, but when there's backups in long-term care, or not just long-term care institutional, but even non-institutional, I think some of the stories we heard actually probably relate to sometimes that transition from the acute care or what shows up in these boxes as well. And then I guess the other question I have, it's maybe somewhat rhetorical, is that we probably have more explicit information about health plan administrative costs, but buried in the claims or in the payments or so forth are the administrative costs that have been shifted to individual providers, right? Hospital bill, think about how much hospitals and practices spend on their billing departments. Now, to a certain extent, some of that is to drive and improve that claiming process, but some of it's because you have, things like pre-auth, right? Sitting there, tying up time. In fact, some recent studies have shown that primary care doctors right now only spend approximately 28%, like less than a third of time doing clinical work, actual clinical seeing patient work. The rest of their time is doing administrative tasks, documenting, all this other stuff. I often argue that we could simply have primary care doctors spend 50% of their time doing clinical work. We could double our primary care workforce instantaneously without having to train anybody new. So, how do we, admittedly, we're looking at this larger cost target, but I also think about how are we spending our dollars? And while we are going to get some information about that, is there some way to, even if it's through sampling or some other way, to capture the implicit administrative costs that have been built in by certain policies or certain behaviors or things that people have done?
Two things I want to note. One is other states do include long-term care. And Rick, back to your point, the purpose for measuring total healthcare expenditures is to try to constrain the rate at which it's growing. Public health expenditures, if anything, are undernourished, I would say. So simply when thinking about the purpose of the spending target, you all should consider it, but you may not want to include it because you're not trying to restrain its growth.
Except potentially, and I think it's worth, to your point, a conversation, just like there's a prioritization on certain things like primary care spend. Is there the conversation that needs to happen similarly around public health and public health spend and the concept around sort of value, like high value versus low value care, and putting some sense of where does public health service, especially in the aftermath of the pandemic or the midst of this phase of the pandemic, how does that fit into our calculation? So not sure that it sounds like we have a lot to learn from other states in this regard, but I think a robust discussion for this group to have as we move forward in this.
You could think about a public health target where the target was actually above your spending target.
That's the point, right? Like, I think my reaction when you first brought it up was like, well, we don't want to get public health spend caught up in constraints, but the idea that we put the value on it even greater, just like we would with the primary care piece of this, as we've talked about, is an interesting notion. So I appreciate you bringing it up and hope that we as a group will consider it. And Don, it kind of gets to some of the things you raised, because public health in many ways is the bridge between so many of the other investments that we make in people's well-being, you know, without totally blowing the limits of this body off. I think it's worth us considering.
Could I just, first of all, agree with the chair? I want to second that. And one of my hopes is that this does become actionable, which is likely to mean greater investment in areas like public health, like primary care, like mental health, like community health. So I want to make sure we have enough granularity of the information to know, I mean, even with rural hospitals versus, you know, big academic medical centers, there may be very different strategies. So really teasing out those areas in the analyses, I think, will be very important.
Yeah, on that note, I'm thrilled you raised mental health, because it stands out to me as one example. You know, it's a sector where a huge portion of the workforce has opted out of insurance-based or public program care because of labor market failures. And so an enormous portion of the care that is being received is off books, really. It's cash. And then, of course, there's the huge numbers of people who aren't getting the care they need because they don't have that cash. I assume we're going to have a conversation about the methodology by which we figure out how much people are spending out of pocket for mental health and similar categories.
Well, that's a good question. I mean, generally, the total healthcare expenditure data will come from payers, and so they know what their members are spending on copays and deductibles within the plan. They don't know what they're spending out of pocket, so that is challenging.
Yeah, that doesn't fall within this. It's possible to do it, but not out of this exercise.
To Elizabeth's point, though, that you keep bringing up, the affordability question, you know, figuring that piece out that Ian's raising, especially in the behavioral health realm, is going to be important for us to contend with, for sure.
Just to second Ian's point, I mean, I think that is to restate it, is that as we are beginning to develop data systems to measure total health expenditures, even though it's going to be hard and maybe it needs some health services researcher getting a grant from someplace, you know, I mean, but we ought to pay attention to it, because certainly in behavioral health, as we all know, it's a very big part. And even something maybe as simple as, you know, using you know, the American Community Survey to figure out how many behavioral health therapists there are in the state, and some you know, estimate of what their average income is, and so what the total income is coming in from that, and comparing that to what the payers are. I mean, there are lots of ways to think about doing this, you know, all of which will be imperfect, but we shouldn't lose track of it, I think, is Ian's point. Yeah.
So that last box on the right, that's what we're measuring when we measure performance against the spending target, right?
Yeah, I think that you know, there are various tools, you know, right? American Community Survey, we do a CHIS survey, right? And again, I think the idea is to say there's a space here we know exists. We maybe get some sampling data. It's not going to be as precise or as good as perhaps the data on some of the other parts, but at least we have a rough idea of that size of that space. And at least saying that, and actually we can see in our analyses some of the signs of things going into that space and back out of that space, right? There may be certain codes or something that may be related where, oh, now and then they sort of disappear in that space or they come back. So I realize that could be fairly sophisticated, but at the same time, I think that pretending it doesn't exist, or I shouldn't say pretending, but, you know, not trying to figure out how to make it somewhat visible, I think that would hamper our efforts. Thank you.
Okay, so this slide just gives some examples of what's claims spending, what's non-claims-based spending. It's probably self-evident. So when reporting in other states is done, I'm continually saying in other states because it's up to you to decide how it's going to be done in California. But at least in other states, there are 4 levels of reporting: state, insurance market, payer, and large provider entity. So state speaks to itself. Market is typically 3 markets: Medicaid, Medicare, and commercial. In this case, commercial is it does not include Medicare Advantage. Sometimes people call Medicare Advantage commercial, but in this case, it's grouped with Medicare fee-for-service. And Medicaid would be both through the health plans as well as direct payments out of DHCS. The payer reporting: Medicaid managed care, Medicare Advantage, commercial carriers, and then the large provider entities have their reporting done by market. So if I'm a large health system and I have a lot of Medicaid, Medicare, and commercial, then I might have my performance reported for all 3. If I'm an FQ8C, I might only have performance reported on Medicaid because my volume of commercial and Medicare might not be large enough to generate statistically meaningful results.
Are there any states in which there is reporting directly from the providers? I mean, if I understood what you just said, the reporting on the providers is done by the payers.
Because we're asking the payers, what did you pay?
Right. Are there any states where the health system itself is being asked, what did you spend? Where Mass General Brigham, or it used to be called Partners, is asked, what did you spend?
No.
And do you have a sense that that's because it's about...
What did you spend, meaning what were your costs? Is that what you mean?
Yeah.
Yeah.
Or either what were your costs? How many people did you take care of? I mean, we're getting information from Massachusetts and other states. My understanding is get information directly from payers about what they paid out, but have not gone to the providers to ask either what they spent or what revenue they've received. And I wonder whether that's because in other states they've thought about it and decided it was a bad idea, or...
Well, because I think they're just focused on reducing spending growth. And so the question isn't what were the providers' costs, although we might want to be sensitive and aware of that, but it was what were they given? What did the payers give them, and what did patients, consumers, give them out of pocket, or at least what was their obligation to give them? Now, there are some states that, although not a lot, but there are some states that collect fairly detailed cost information from hospitals principally, but not for other provider types. And usually those are programs that preceded the spending target and are sometimes loosely connected to analyses, sometimes not. I will share with you in one state, they use some of that data when there were voiced concerns from hospitals about the cost shift. And so they were able to use some of that information that they collected from hospitals. But generally, they are separate initiatives. Doesn't have to be, but that's just the way it is.
Will the payer reporting include PBMs and drugs?
So the reporting of total healthcare expenditures includes drug spending. So if there is a payer that's using a PBM, then that PBM spending is part of the spending, but there's not separate spending on PBMs.
Well, now they're all owned by the plans anyway,
Right.
So maybe we could include them.
Well, so the reason that they're not included is because the measurement is of total healthcare expenditures, and that's a portion of healthcare expenditures. So you could have it as a separate complementary analysis, but if you're measuring total healthcare expenditures, it's sort of an all-in measure. Does that make sense?
So just to follow up on what Iconic talked about, we are collecting financial, we're requiring everyone to provide financial, well, large entities, including large medical groups, so it's not just hospitals, to provide. Given that, are there analyses we should be doing to sort of do that connect between, okay, this is what the plan said, but this is what the hospitals are saying, right? And the large medical groups, like, just because another state isn't doing it, is someone looking into how we can, if nothing else, cross-check with each other, right? We're talking about certain I was going to say black holes, but gaps or data voids, right? Because perhaps, I'd be very interested in looking at what's going on in the emergency room, because that's where the interface is between people who are in a plan and then people who aren't, but the results of either an absence of service, right, then when it hits a crisis, tends to show up in the emergency room. There are some things we should perhaps think about that, since we're collecting the data anyway, and believe me, there was a lot of screaming, yelling about how much data we're trying to collect. Yes, but since we're collecting it, is there a way we can use it? I guess that's the thing.
I'll let that question just hang. Right. I want to give you a few examples from different states of how they've reported out spending. These are not meant, these are not recommendations, but just to give you an example. So this is Massachusetts component of healthcare spending 2019 to 2020. They actually just reported 2021 last week. And you can see here, they reported by market segment and what the trend was within the market. Now in 2020, nationally, healthcare spending as reported by states went down. We know that nationally, healthcare spending actually went up, but it was mostly federal spending that doesn't appear in anything that states collect. So with data that states do collect, spending went down. And so you can see they had a minus 2.4% trend that year. And here they break apart what the trend was by payer category. This is a little different. This is a breakdown for their Medicaid program, which goes by the name Mass Health. And so it's a breakdown of what was happening in categories of payments within their Medicaid program. And the total trend, and then the trend by category. This is an example of breaking down spending into service categories. This comes from Connecticut. I think this was total spending. Now they also do it by market. When they report publicly, but this is across markets. And the larger the circle, the bigger the contribution to trend. So this was reporting, I believe, on 2019, because overall spending, the trend was positive that year. So we can see that just visually that hospital, outpatient, and retail pharmacy were the two biggest drivers of healthcare spending growth in the state that year. Those percentages are the per capita rates of growth for that 1 year. So why does hospital outpatient have a bigger circle if it grew at 6% and pharmacy was 7%? It's because the total spending for hospital outpatient was larger than retail pharmacy. This is reporting at the insurer level from Delaware. They don't have a lot of insurers, so they can put them all on one slide here. This is for 2020. Spend was negative, although somehow Aetna grew 5.5%. I'm not sure if that was a reporting error or not. But I'm sharing this as an example of a state that's naming names. They're making public how did each insurer in our commercial market do in 2020. And all of the other states name names when they report on insurer performance, as they do at the provider entity level. And here's
that data does that data include shareholder data for the payers?
So this is on total healthcare expenditure change from 2019 to 2020. So these are payments that were made by each of these insurers in the commercial market on a per capita basis. Okay, Yeah, all the measurement is per capita. So this is a provider level example. This is for commercial ACOs. That's the level at which they do reporting in Rhode Island. They do it for ACOs, which their small delivery system is organized by ACO, so it makes sense there. This is also for 2020. Their per capita target is 3.2%. So they report the results in confidence intervals so that you can determine how sure you are of performance. All of these confidence intervals are below the target. If any of them cross the target, that would mean we're uncertain whether they met the target or not. If the confidence intervals were all above, we would say they didn't meet the target. So in this year, 2020, they all met the target.
Michael, just going back to Sandra's question about shareholder admin cost. So total healthcare expenditures includes admin costs and profits.
Yes.
So it would include money that was paid out to shareholders. I just want to make sure we're answering that directly.
Well, no, we don't know about payments to shareholders. We know
the
profits.
admin costs and profits amount.
Right.
And not. Okay.
But the profit
Right.
amount is
Earnings
part of the analysis of total spend, right?
Yes.
Profits is, yes.
Right. What happens to those profits? We have no idea. Okay, so finally, I'm going to come back to your question, Elizabeth. Do these actually work? As I said earlier, only Massachusetts has been doing this long enough to have a track record for us to look at. So, as I said earlier, legislation in 2012 established the program. It also established a body called the Health Policy Commission, which has authority to monitor compliance with their target. The accountability mechanism that it has right now is only a performance improvement plan. They never applied it until last year. So 10 years until they first applied it. They also do other analysis of...
Michael, was that for political reasons? Was that for political reasons? It took them 10 years?
I can't say. To be honest, I can't say. I think the state has said that in this period, it was not inactive or silent, but in fact was providing feedback to provider organizations and having meetings with them about their performance. That's all I know. So they have an annual cycle. You will have an annual cycle of collecting data, analyzing it, and reporting out. In Massachusetts, they have a separate state entity called the Center for Health Information and Analysis, which is really here. But they do the analytic work, and then the Health Policy Commission advances the policy agenda. So I want to share with you 2 slides with data. So this first is per capita trend in Massachusetts since they created their target. So I can tell you a couple things here. One is over the first 6 years, the rate of growth averaged out was 3.6%. Their benchmark in statute, 3.6%. Okay? Some years above, some years below. One of the years above is a year that Massachusetts refers to as the Sovaldi year. But you know, spending growth was around the benchmark, or they call it the benchmark target for California. And then they had a pretty big increase in 2019, which set off some warning bells because that was 2 years in a row that they'd been above. And then COVID and spending dropped.
Michael, are these data per capita,
Yes.
as in dividing by the total state population, or risk adjusted per capita?
So it's not risk adjusted.
Just per capita.
It's just per capita.
Thank you.
Okay. This is a little nittier and grittier than I wanted to get today. They use the state population for their denominator. Other states do not. Other states use the covered population. Okay. All right. So so I would say, for the first 6 years, Massachusetts spending growth was about where they set their target, and they set their target below where the historical spending was. Okay, but some worrisome trends here in 18-19, and they just published 21, and 21 was above. Okay, which isn't shocking given the drop in 20. Okay.
Can I ask before you move on the denominator question, is Massachusetts sticking to that because it's in their statute? And if they were able to evolve it, they may have adopted?
I don't know.
You don't know? Okay.
Yeah, I haven't asked them that question. I don't know. Okay, so to me, this is the most telling slide, because what we really want to see in terms of impact on spending is what happens in the commercial market. And what we can see here is that prior to 2013, Massachusetts commercial market spending was above the national rate of growth every year. Okay, 1 year, 2009, a little below, but generally above. As soon as they create their spending target, their spending is below the national rate of growth every year. And they've calculated that delta between the blue line and the orange line as amounting to something like $7 billion of reduced commercial spending. So for me, this is the most telling indication that their target had an impact in the commercial market, which is the market that most needs to have the impact. I will let you know that the 2 years that follow this, 2020 and 2021, didn't look as good, right? And what does that mean? This is my personal opinion, not rooted in data. I think that transparency gets you only so far. And I think transparency had a really good run in Massachusetts. But Massachusetts right now, I think, needs to do something else. And the Health Policy Commission believes it needs to do something else. In fact, they've made recommendations to the legislature the last 2 years to give them expanded authority to be able to do some things that they can't do today. So this is my assessment of do spending targets work? I think for me, the answer is on this graph, yes, certainly for a while. They have impact. Okay, now remember, this is not reducing spending. It's just slowing the rate of growth. That's a really modest expectation, saying all we're going to do is slow it. It's not reducing spending. And the people who testified today, who talked about their out-of-pocket spending, this does not solve their problem. All right, so why might it have been successful in Massachusetts? Because all of these initiatives take place within a state-specific context. So what works in one state isn't going to work in another state. And I can share that doing this work in multiple states, the cultures and the overall environment, they're just so incredibly different. So in Massachusetts, I think it worked because I think that to some extent the Attorney General's office had roughed up the market prior to them establishing this, and had been really rough on the provider organizations about their spending growth, and so there was some sensitivity to being called out. And then the legislation created a common goal of one number. It was 3.6%. It was established, fixed for, I forget, 5 or 6 years before it could even be changed. That applied well in a state in which there was a lot of total cost of care contracting, so lots of risk-based contracting, where insurers and providers were negotiating each year on a trend number. And lo and behold, here in legislation, we have a trend number. So it translates directly into a contractual application, and it influenced negotiations. Finally, the state was transparent about performance. There not only is a big report, and the Massachusetts Health Policy Commission puts out reports that are amazing, but they hold an annual hearing. And the hearing is live broadcast. In its early days, it had overflowing crowds attending them. The governor comes to testify, the leaders of the legislature come to testify, the attorney general comes, they bring forth insurer executives, hospital executives, they have to sit in front of the policy commission and answer questions. There's a lot of public visibility and I would say drama that draws attention to this activity. So I think those are the contextual factors that helped make this effective in Massachusetts. It doesn't mean it's going to make it effective anyplace else, but I think it's worth understanding that context.
Where, before they started this effort, where were they ranking across the states per capita healthcare spend? And right, exactly. And now, are they more in the middle?
No.
They're not.
No,
So,
but they're not at the top anymore, and they take pride in that.
This is the home of Harvard, of 3 medical schools in one small city, or not such a big city. Yeah.
Yeah. Yeah. Well, I mean, this goes to the point that I made smiling at Elizabeth a minute ago. All we're talking about is slowing the rate of growth. We're not saying let's take 10% off of healthcare spending, which a lot of consumer advocates would like.
And the transparency effect on the absolute outlier is usually effective. And then when you start to feel like you're more in the middle or just not at the top, it starts to diminish, I think is one of the points you're making.
Yeah, I think, well, as I said, transparency is very important, but it's not enough. And it's why I have the logic model with the left side, because I think that there need to be supplemental activities that are being done. And there needs to be some enforcement, which you have in your statute.
Right. Well, and you left Dr. Pan's point about data and what we're collecting aside, but I think at some point we'll have to look at what we worked hard to have people submit to us and how useful or not useful it is, because it sounds like that's a place to tap potential support in the mission of whether it's setting the target, enforcing it down the road, or any of the activities in between. I think it's useful to figure that piece out at a later meeting.
Yeah, I left it hanging there because I think the real question is, will it aid you in your quest to improve affordability? And I don't know the answer to that. Okay, so I have run through my content. I just want to let you know that there is one slide here, if you want to look at it later on your own, that has the target values for all of the other states, what their methodology was, and what was the historical spending growth in the state for the decade 2011 to 2020. So for you to consider another time, we'll talk about some of this information on another day, but that's what I had for today.
Thank you, Michael. So I'll now review the next portion of our agenda related to the spending target development timeline and the review of our meeting plan. Next slide, please. Next one. Yeah, thank you. So developing the spending target and related total healthcare expenditure measurement and reporting specifications will involve a series of monthly meetings with the board to discuss those design decisions we mentioned earlier. So up until Q3 of 2023, we will focus on the methodology for measuring and reporting total healthcare expenditures. These design decisions include, but are not limited to, the levels of reporting, calculations for year-over-year percentage change, strategies to ensure data is reported that is complete and accurate, adjustments to spending target performance. So that'll take us all the way up until Q3 of 2023. And then the Q4 of 2023, this is when the board would begin discussions to establish California's 2025 statewide spending target. During this time, we would also issue regulations for collection of total healthcare expenditure data, which will be used, those regulations will inform data that's also collected for calendar years 2022 and 2023 for the baseline report. And with regard to the spending target methodology, that's going to include a discussion of indicators that could be used to inform the target. We're going to look at historical versus forecasted values. We're also going to consider adjustments to the spending target that are included in statute or other considerations. And then throughout this process, we would seek input from the advisory committee and receive public comments related to proposed spending targets. So in terms of spring 2024, as I mentioned earlier, we have that March deadline of the office proposing potential targets, and then the board would have until June to approve the 2025 spending target. In summer of 2024, payers and fully integrated delivery systems would submit their first THCE data submission covering 22 and 23. And then as we move to 2025 on the timeline, this represents the first year of statewide spending target implementation. As I mentioned earlier, this is a reporting year only, and the first and would not be subject to enforcement. Moving on to spring of 2025, the board would adopt a 2026 statewide spending target, again based on those March and June timeframes. The board does have the option of selecting opting to do multi-year targets, so it'll kind of depend on what approach the board takes, whether to set an annual target or set a multi-year target. And then moving on to 2026 in the timeline, the 2026 target would be the first enforceable target. And then during this year, the office will also publish the baseline spending target or baseline health spending report covering 22 and 23 data. In spring 2027, the office would issue its first annual report covering the period 2024 and 2025. So this report would cover measure the year-over-year change because it would cover the 2025 target. So it would measure the change between calendar year 2024 and 2025. And lastly, by fall of 2027, as indicated in the statute, the board has the authority to define initial healthcare sectors. That, the timeline on here is just shown for the next 4 years. The board would first need to define those initial healthcare sectors on or before fall of 2027. And then once those are defined, then the board could take action to define specific targets for the sectors based on those March, June timeframes I mentioned earlier. So that concludes the kind of an overview, and I'm happy to answer any questions from the board.
Yes.
Thank you. When will we be discussing sort of the methodologies in more detail? Will that be in our next meeting, in the data sources and alternative measurement approaches? Is there any time between now and the next meeting, or if that's in the meeting?
So the monthly meetings that we're scoping out right now, they would involve the design decisions for total healthcare expenditures. So some of the things that Michael just went over in his presentation, the levels of reporting, you know, statewide, market, payer, provider, and then also adjustment methodologies, which would include risk adjustment and equity adjustment. So those are going to be all the way, most of 2023 will be focused on that. Yeah.
Other questions from the board about upcoming agenda items and meetings?
What's the time frame for appointment of the advisory committee? So I assume we were soliciting, the department soliciting, so anyway, I guess what at some point we probably should talk about composition, right? And then, you know, there's going to be a process for the actual appointment, right? And obviously the statute does provide some guidance in terms of composition.
So yeah, thank you. And I did want to include a reminder to members of the public that we have on our OCA website a submission of interest form for the advisory committee, and we have asked that folks submit those by April 15th. So by April 15th, we'll have the submissions and can at a later meeting present that to the board, and if the board would like, make suggestions about some possible composition. And then yes, the board will appoint the advisory committee. We will now take public comment on.
Sorry, so just so we're looking at, I mean, May for appointing the advisory committee? Okay.
Yes.
Thank you.
We'll now take public comment on item 5 as well as general public comment.
We'll be starting with the virtual room this time. So moving to Catherine Sullivan, you are unmuted. Please go ahead.
Hello, I had talked earlier, I'm Dr. Catherine Sullivan. I am coming more from the Medicare population-based side of this, and my concern with your cost target is you're not looking at anything related to cost savings. So I think that's what a lot of the public is interested in, is not having the targets only be set at cost, share of costs, but what can we do for cost savings? And one strategy is to look at the total cost of care per year, because a lot of times the acute care costs are very high, but if you have more of a rehabilitation model, you can get the cost per case per year down. So that's just an idea for consideration of targets.
Thank you. Now looking to members of the public in the room. Please go ahead.
Beth Capel, Health Access California. This has certainly been a very rich discussion and the start of a number of other discussions. The experience, we hope the experience here in California will be a little different than the experience in Massachusetts, precisely because you have the progressive enforcement that the staff detailed earlier, including culminating with not only commensurate but escalating penalties, or to put a finer point on it. When the legislation was being enacted, Mass General exceeded their target by $293 million. And what I said in public testimony was that would be the penalty in California. So that would be enough to get almost anybody's attention, I should think. Or better yet, the threat of it, that we should never want to have to use those penalties. We should want the existence of the possibility of those penalties to improve the ability to comply with the cost targets. The other side of this, and I meant to speak to this earlier, but I had been rather over my time. Part of what underlies this law is the California version of the triple aim of lower costs, better outcomes, and improved equity. That's why primary care, behavioral health, alternative payment models, and all of that are equal obligations, that we're not trying to just eliminate care, we're trying to actually transform care so that we do it better. And that doesn't make your job easier, but it's all part of a larger vision of getting to a very much better place in terms of how we deliver healthcare in California. Finally, I will note we're going to be offering numerous
10
comments
seconds.
on California-specific aspects, such as our self-insured market's a lot less than 50% of the commercial market. Thank you.
Thank you. Any further public comment?
Yes, we'll move to the virtual room. We have Joseph coming in. Joseph, you're unmuted. Please go ahead. And Joseph, you're unmuted on our end. You'll have to unmute on your end also. All right, we'll give Joseph a moment. Any additional public comment in the room?
Hi there, my name is Anthony Wright. I'm the Executive Director of Health Access California. My colleague did the item 5 comment. I'll do the general the general comment public. But I wanted to just again say my appreciation for the already all the great work of this board and obviously the staff and administration on working on this really exciting undertaking, one that we feel a lot of urgency about and also a lot of ambition. And with regard to that ambition, one that the
hail has arrived.
That has atmospheric intentions. I want to present to this board a set of principles that were developed by Health Access, consumer goals and guiding principles for the Office of Healthcare Affordability, something that's developed with our staff, with a set of experts, our conversations with advocates in other states, about what the ambitions are. And this also comes out of my own experience being in those rooms over the last 5-6 years from the very beginning and throughout. These are not things that were these were things that were in the conversations at the very beginning, which is we want to look at controlling the overall cost of spend, but also make sure that it provides real relief to consumers at the end of the day, and that we build that into the process. That's something that the folks in Massachusetts wish they had done in the beginning. We want to make sure that we embed equity into the beginning. We made sure that we had the accountability, but also the flexibility to deal with the specific issues that Californians have. We want to make sure that we value transparency, but it's transparency and tracking trends, not for transparency's sake, but for taking action, for actually being meaningful with regard to how people, purchasers, policymakers can use that, including your own power that you have been endowed. We want to make sure we're lowering costs, but it's also to the point of value and to really getting to the point of cost, quality, and transforming the healthcare system. And finally, that we're not just looking at cost drivers, but the entire healthcare system. This is the unique place in state government where you are looking at not just the individual insurance market or the managed care market or whatever, but the whole system as a whole. And that's a very advantageous place to make these kinds of transformational changes. And finally, also in these principles, which I'll hand, is that to do this, we encourage you to embed the consumer voice and community voice in every aspect. Yes, taking public testimony, but embedding it into analyses, finding ways for that analysis to be informed throughout the process. And happy to talk further about that. Thank you very much. And again, congratulations.
Thank you.
Can you hear me? Okay. Sorry, we have Joseph Brown again.
Yes. Good afternoon. My name is Joseph Brown. I'm an interventional radiology tech in Roseville, California. I appreciate the opportunity to speak on these issues at this board meeting. I've been a healthcare worker for 13 years and am a proud member of SEIU UHW. I'm proud that my union, SEIU UHW, bargains the best contracts possible when we sit at the table with our employers. However, the growing cost of healthcare is being weaponized by our employers as a roadblock to good contracts every time we bargain. Employers try to increase out-of-pocket costs that workers pay for healthcare and cite rising health insurance costs as an excuse for why they can't give sufficient raises to recruit the next generation of healthcare workers or retain the experienced healthcare workers that are needed to train them. This has exacerbated an already tenuous healthcare staffing crisis. California will need more than 500,000 new healthcare workers in the next decade. Patient exams at my facility are routinely rescheduled to sick calls and emergencies. Some of the patients have waited weeks or months to get on the schedule for these life-saving procedures. This risks increased mortality rates for our patients and places an unnecessary burden on our patients and healthcare workers in the form of stress and anxiety. My facility and many others have seen significant increase in workplace injuries and workers taking stress leave due to short staffing and overscheduling. The age and acuity of the patients in our communities is increasing. And until employers invest in their workforces to meet this demand, the cost of healthcare will continue to rise. Will healthcare workers have to choose between caring for your family or your neighbor's family when they are at their most vulnerable? I'm excited for this healthcare affordability board to join the fight with UHW to control rising healthcare costs and to fix healthcare staffing crisis in this great state. This office is a critical step in slowing the growth of healthcare costs, and our hope is that your success will mean more money in the pockets of working people and their families. Thank you.
Thank you.
To Dennis. Dennis, you're unmuted. Go ahead.
Okay, great. Hi, everyone. It's good to see I'm not the only one dealing with the hail right now. My name's Dennis Anderson. I am a phlebotomist at Dignity Folsom. I've also been a healthcare worker for 23 years, and I'm a proud member of SEIU UHWs. So in our hospitals, we've seen how high healthcare costs hurts patients. I mean, whether it's we see patients who have delayed necessary care and whose conditions just get worse due to that delay. We see patients who we know cannot afford the follow-up care that they need to help them and to fully recover once they leave the hospital. We see patients for whom the most stressful part of being in the hospital is the knowledge that they and their family cannot afford the bill that they have to pay. I've had the privilege of working emergency rooms all across the state of California. In Folsom, I've been working in that emergency room for 10 years. It's a small community, and you see a lot of familiar faces. You see your neighbors. You see even patients that the most vulnerable amongst us who are looking for care. And as healthcare workers, we I shouldn't say this at a public meeting. We bust our behinds to make sure that every single patient gets the quality care that they need. But it's terrifying sometimes. It can really hurt when you see people who need this care, and the first question is not, how can I recover from the sepsis? How can I deal with this cancer diagnosis? The first question can many times be, what is the bill going to be? How much is this going to cost? How much does this drug cost? And so I want to say we're looking forward to this board's work and making sure that healthcare is affordable for all Californians. Thank you, everyone.
Thank you.
Carmen, go ahead. Carmen, you're unmuted.
Good afternoon. This is Carmen Comsty again, lead regulatory policy specialist with the California Nurses Association. When talking about healthcare costs and spending, CNA first wants to underscore the issue of savings that earlier commenters noted. A single payer universal healthcare system like CalCare will ultimately ensure that we can save on administrative spending and place California in a position to negotiate lower prices while also providing comprehensive care to all Californians, but we pay less. As touched upon today, CNA is concerned about how spending targets may ultimately be deployed in our state. We strongly urge the board to ensure that there are not that these spending targets are not used to contribute to denial or limitation of care, particularly through the use of prior authorization or other insurance barriers, payment incentives to reduce care, or capitation by payers. We unfortunately know that the most vulnerable who need higher levels of care, like those with chronic conditions or disabilities, may be the first who has their care limited by providers or insurers in attempts to meet spending targets. Attempts to reduce costs should not incentivize crisis standards, care rationing, or short staffing by healthcare providers and failures to spend investments to retain healthcare workers through safe working conditions and safe practice conditions. CNA expresses our concern about the use of strict spending caps. As discussed, adjustments for inflation and other changes in healthcare needs are necessary. For example, people with long COVID may ultimately increase the amount of care needed, and spending targets should be adjusted upward accordingly. Recognizing these are just beginning discussions, CNA continues to underscore that attempts to reduce costs should never incentivize the reduction in care. Thank you again, and again, looking forward to the discussions.
Thank you. That appears to complete all of the public comment.
Thank you, everyone, for such a robust, successful first meeting. Again, the OCA webpage includes a submission of interest form for the advisory committee, and we request that those be submitted by April 15th. And also, public comment can be submitted in writing to our OCA email address. I will now move to adjourn if there are no objections. We are adjourned at 5:06. Thank you.
Thank you.